Ladies and gentlemen, it gives me great pleasure to welcome all of you in this series of webinars organized in collaboration with the World Federation of Neurosurgical Societies, the WFNS, the Mediterranean Association of Neurological Surgeons, DEMANS, and the Continental Association of African Neurosurgical Societies, the CANSUN. This is part of the 100 webinar project, which was initiated with the beginning of the COVID-19 pandemic. We started our first webinar 29th May 2020. We already organized 69 webinars. Many of them are WFNS educational symposia. Today is webinar 70. This is a collaboration between the MANS and the International Academy of Spine, the IAS. And in this context, I would like to thank my friend, Professor Oscar Alvis, co-chairman of the International Academy of Spine, of such opportunity to have this wonderful collaboration. First of all, let me thank all our distinguished speakers. I will go by the order by which they speak. Aysam Abdul Menem from Egypt, Jamil Kitumba from Angola, Fernando Dantas from Brazil, Saleh Bisa from Saudi Arabia, Ricardo Jip from Brazil, Oscar Alves from Portugal, Onur Yaman from Turkey, Ricardo Botelho from Brazil, Mehmet Zelili from Turkey, A. Fushi from China, and finally, Massimiliano Visucci from Italy. Thanks to all of you for contributing to this neurosurgical activity and for giving us much of your time. Sharing your knowledge and experience with neurosurgeons across the globe is well appreciated. We have an outstanding program from today. We have 11 speakers and we have 3 sessions. At the end of each session, there is discussion. This webinar will be terminated 5:30 Egypt time exactly, or 3:30 p.m. GMT. As you can see from this screenshot, this webinar is fully booked. We will reach the maximum capacity after opening registration for a few days. We have 500 registrants for these webinars. To all attendees, we are glad to get all questions and comments, and it will be monitored by the moderator, Oscar Alvis, through the Q&A panel. This is a certificate we are offering. Certificates will be sent to you automatically. There is no any need to have a link. Remind you, in order to get your certificate, you have to participate from the beginning to the end of the webinar. Our series of webinars is organized either in collaboration with the Education and Training Committee of the WFNS, scientific committees of the WFNS, neurosurgical societies, whether national, regional, or continental, sometimes with well-known universities such as University of Miami. The maximum capacity of each webinar is 500 registrants. However, in some webinars, the organizing committee extends the capacity and open registration again for a limited time. This shows the number of registrants and participants in last 12 webinars. The maximum participation in the WFNS educational symposia. Of course, not all the registrants participate. Last webinar, 768 participated. I'm sorry, 768 registered. However, only participated 428, and certificates were sent to only 162. Those who participated from beginning until the end of the webinar, 3.5 hours. Webinar today is 3.5 hours. You can also follow our webinar series from this YouTube channel. I will leave to you the QR code in order to scan it. However, not all the webinars will be available in the YouTube. That is decision of the organizing committee. I'm also glad to announce about the Pan-Arab Journal of Neurosurgery. I am honored to be the editor-in-chief of this journal. Both submission and publication are free. This is the QR code. Again, if you like to scan it by your mobile. Our next webinar, webinar 71, takes place Friday, 31st March 2023. It will be a collaboration with the Craniovertebral Junction and Spine Society, and it will be a collaboration with El-Ghandour. As you can see over the screen, we have a galaxy of eminent speakers. I'm also glad to announce about the 14th Asian Congress of Neurological Surgeons Congress, which takes place in Egypt from 28 to 30 November 2024. I'm glad to be president of this Congress, and I'm glad to work with Professor Yuko, who is president of the ACNS. All of you are invited. I think it will be a good opportunity to visit together the Grand Egyptian Museum. Thank you very much. Now I will give the mic to my friend, Professor Oscar Alves, to say his welcome note and then start the scientific sessions. Thank you.
Thank you, Nasser. I think the first word has to be to Nasser. He is doing a wonderful job organizing this webinar. For me, it's the best educational online activity that we have in neurosurgery nowadays. So you really receive a great congratulations.
Thank you.
For this topic, and actually it's the second time I'm collaborating with you, Nasser. We did a previous webinar on frontline spine surgery. And this one, which was the topic on craniovertebral junction anomalies. And I had the pleasure to invite many of our friends, which are actually also the great experts on the topic worldwide. And we have a very attractive program. And without any further delay, we should start with the first speaker. And I call all the speakers to keep in time, because we need to finish and give some time for discussion. So I call Professor Manem to talk us about the classification and clinical picture of craniovertebral junction anomalies. And this will be an overview of our topic today. Thank you. Could you please share the screen, Professor Manem?
Is it clear now, bro?
Yes, okay. Just go to screen mode on the bottom right. Screen mode. Next. Oh, yeah. Yes. Perfect.
Okay. Good afternoon from Cairo, Egypt. I'm Dr. Isam, consultant in neurosurgery from Organization of Teaching Hospital, MOH. I'd like to express my deepest thanks to Professor Dr. Nasser El-Ghandour and Professor Oscar for this kind invitation to share in this great event. This evening, I'll talk about craniovertebral junction anomalies, classification, and clinical picture. Anatomical introduction. This craniovertebral junction is the junction between base of the skull, mainly occipital bone around foramen magnum, C1, C2, together with intervening ligaments and tendons. These structures must be critically aligned to surround the inferior part of brainstem, together with medullocervical junction and upper cervical cord, with the lower cranial nerves and lower part of cerebellum, surrounded by CSF and including vertebrobasilar system. These critical anatomical relations are described through craniometry. Craniometry is mid-sagittal section through the craniovertebral junction with imaginary lines to describe these critical normal anatomical relations. The first line is this line number 1, passing through mid-plane of clivus down to the spinal canal. Normally, tip of odontoid is always ventral and tangential to this line. Second line extended from back of hard palate to the back of foramen magnum. Normally, tip of odontoid process must be 3 to 4 millimeter below this line. Third line extended through the foramen magnum from the anterior lip to the posterior lip of foramen magnum. Normally, cerebellar tonsil must be always above this line, and tip of odontoid must be always below this line by about 3 to 4 millimeter. Fourth line is modification of the second line, extended from back of hard palate to the lowermost point of occipital curve. Fifth line is the vertical line from tip of odontoid to the tuberculo-turcular line. Normally, this line is 40 to 41 millimeter. Sixth line is the spinolaminar line extended to the posterior lip of foramen magnum. Normally, this line must be slightly lordotic and always smooth without any step-offs. Classification of craniovertebral junction anomalies may be either congenital or acquired. Congenital, I mean presenting since birth. So it is malformation of either occipital bone, atlas, and axis. Before going into details to these malformations, we will go to the embryologic origin of these three items: occipital bone, atlas, and axis. It is broatlas. Broatlas is the fourth occipital sclerotome. From this broatlas, derivatives will come to end by this part. We will mention it in details in the next slide. After formation of these end products, broatlas normally fuses and disappear with the upper three occipital sclerotomes. In some exceptional abnormal cases, this broatlas may fail in the process of segmentation and diffusion, so it will continue to be present after birth, and it will appear in the CT scan as broatlas or something called third occipital condyle. The derivatives of broatlas are the following. Number one, anterior tubercle of clivus, apical cap of dens, apical ligament, the U-shaped anterior margin of foramen magnum, occipital condyles, cruciate ligament, alar ligament, lateral masses of atlas, and superior portion of posterior arch of atlas. Manifestations of occipital bone malformations are the following. Number one, what's called occipital vertebra. Number two, basilar invagination and platypesia. Number three, condylar hypoplasia. And lastly, assimilation of atlas arches. Occipital vertebra is very rare anatomical variant, result from incomplete or apparent fusion of occipital bone ossification centers. Wide variations of occipital vertebra are present. We will mention these manifestations of occipital vertebra. Number one, clivus segmentations, where we will find elongated clivus with deficient anterior arch of atlas, as we see here, plus congenital posterior atlanto-occipital dislocation due to failure of broatlas in fusion and segmentation, plus minus associated other anomalies. The other manifestations of occipital vertebra, including remnants around foramen magnum, atlas variants, dense segmentation anomalies. Basilar invagination is prolapse of vertebral column into the skull base. As we see here, it is passing this line we mentioned before. frequently associated with other anomalies like vertebral occipitalization, vertebral assimilation, and vertebral block, and others. Basilar invagination will be mentioned in details in the coming presentations. We will just see now, this is the vertebral occipitalization in CT scan. It will be like this. And this is the vertebral block. Platypesia. To mention platypesia, we will start by talking about basal angle. Basal angle is the angle between base of anterior fossa and clivus. This basal angle, this one, it is normally from 125 to 143 degree. In platypesia, this angle is more than 143. In basilar kyphosis, this angle is less than 125. In platypesia is increase of the basal angle, which is flattening of the skull base, may occur congenitally or developmental, and may compromise brainstem, lower cranial nerves, and cerebellum. Condylar hypoplasia occurring due to malformation of pro-atlas. BAX1 gene is mostly involved in the process, may lead to narrow foramen magnum, may lead to lateral medullary compression, transient vertebral artery compression, posterior subluxation of the occiput, plus minus third occipital condyle. It will appear like this. Assimilation of atlas arch, another name, occipitalization of the atlas or cervical synostosis. It is the union of the atlas with the occipital bone. It may be partial or complete. It is the most common anomaly of craniovertebral junction. So the foramen magnum changed from this normal shape into this abnormal shape with inferior articular facet from the atlas in the inferior basal view of the skull. And this is the foramen magnum. This is the abnormal shape foramen magnum. In the CT scan, it will appear like this. So now we finish the occipital bone. We'll go to atlas, then we'll go to axis. Malformations of atlas, number one, what's mentioned now, assimilation of the atlas. Number two, atlantoaxial fusion. As we see here, here is fusion between anterior arch of atlas and odontoid process. Number three, aplasia, hypoplasia, or split of atlas arch, as we see here. Split of anterior arch of atlas will appear like this. Malformations of axis, including number one, irregular atlantoaxial segmentation. Number two, dense dysplasia. Number three, segmentation failure of C2-3. Irregular atlantoaxial segmentation is rare type of skeletal dysplasia, interferes with bone development. So it is something systematic in the whole body, including our area of interest. Dense dysplasia, including ossiculum terminal persistence, os odoitondium, hypoplasia, aplasia. Ossiculum terminal persistent, we are talking about this small piece of bone. So it is small, well-corticated ossicle of the tip of the odontoid of the dens. Usually in midline, dens is normal in height. It arises from secondary ossification center in dens, not normally fused and disappeared by the age of 12 years old. The differential diagnosis is os odoitondium and type 1 fracture odontoid. The second anomaly is os odoitondium. It will be mentioned in details in the coming presentations. Just I want to say one word about os avis. Os avis, when the separated tip of odontoid process is fused with the clivus. In hypoplasia or aplasia of the odontoid process, we'll see this image. Segmentation failure of C2-3 may be part of Klippel field anomaly, and the intervening disc may be rudimentary or may be absent. Vertebra may be widened, flattened, or small, and it may be segmental, fused, or regional. Now we finished the congenital, we'll go to the acquired. The developmental and acquired abnormalities of craniovertebral junction, including number 1, abnormalities at the foramen magnum, number 2, atlantoaxial instability, abnormalities at foramen magnum, including secondary basilar invagination and foraminal stenosis. Secondary basilar invagination, which is basilar impression, is abnormal upward invagination of the area of foramen magnum, may occur due to softening of the bone, like what happens with Paget's disease, osteomalacia, rheumatoid cranial settling, and renal rickets. The image will be like this. Stenosis of foramen magnum may be part of another generalized anomaly like achondroplasia. So image will be like this. Atlantoaxial instability may be due to errors of metabolism, Down syndrome, infection, inflammatory, traumatic, tumors, and miscellaneous. Chiari malformation, usually associating craniovertebral junction anomalies. It is collection of hindbrain abnormalities, and it will be mentioned in details in the coming presentations. Clinical presentation of craniovertebral junction anomalies may be, number 1, asymptomatic, so it will be incidentally discovered. Number 2, classical clinical picture will be mentioned in details in the coming slide, or maybe clinical picture of associating anomalies like Chiari malformation, or maybe clinical picture of complications like repeated pneumonia. The classic clinical picture of craniovertebral junction anomalies may be manifestations either skeletal, neurologic, or vascular. Skeletal including head tilt, short neck, low hairline, limitation of neck movement, web neck, scoliosis, features of skeletal dysplasia, other general manifestations like in rheumatoid arthritis. Vascular manifestations including vertebrobasilar insufficiency. Neurologic manifestations will arise from lower bones, medulla oblongata, medullocervical junction, upper cervical cord, lower cranial nerves, cerebellum, and CSF entrapment. From lower bones, we will get nystagmus. From medulla oblongata, we will get disturbed consciousness, sleep apnea, respiratory irregularity, basilar migraine, dysarthria, vertigo, ataxia. From medullocervical junction, we will get pyramidal decussation problems leading to weakness of any type, either monoplegia, hemiplegia, cruciate hemiplegia, paraplegia, or quadriplegia. From upper cervical cord, we will get motor disturbance with hypo or hyperreflexia, positive Babinski sign, sensory disturbance, autonomic disturbance, together with occipital headache. From lower cranial nerves, we will get dysarthria, repeated aspiration pneumonia, dysphagia, tinnitus, hearing loss, vertigo, glossal atrophy, facial sensory loss, trigeminal and glossopharyngeal neuralgia. From cerebellum, we'll get ataxia and clumsiness. From CSF, entrapment due to compromise of exit foramina of Luschka and Magendie with fourth ventricle and central canal of spinal canal, plus minus syringomyelia. This will lead to manifestations of hydrocephalus, aggravated pre-existing hydrocephalus, spinal cord manifestations. Other manifestations, mainly in Chiari malformation, including drop attacks, urinary incontinence, hiccups, hoarseness of voice, sinus bradycardia, oscillopsia, esotropia. Conclusions: craniovertebral junction anomalies, including critical details due to relatively narrow space with overcrowded structures, bony, ligamentous, nervous, vascular, membranous, and fluid. All these structures are critically aligned. Alignment of these different structures is normally maintained through full range of movement, especially flexion, extension, and rotation of head and neck. Life-threatening and serious complications of craniovertebral junction anomalies should be prevented by proper diagnosis and effective treatment. Craniovertebral junction anomalies patient and family must be informed the restrictions in the daily life and in other medical specialties interventions like in regular sport, military service, endotracheal intubation, dentist, physiotherapist, and so on. Thank you.
Thank you, Professor Essam Monem. This was really an outstanding overview, and it will frame the next presentations. So we'll have some discussion at the end of this module of presentations. And I call next Jamel Kitumba to talk about Chiari malformation, clinical and radiological criteria for diagnosis. Dr. Kitumba is a neurosurgeon from Angola. He's a big hope for sub-Saharan African neurosurgery. He trained with me for 6 years. And actually has to be congratulated twice because his twins were born just 5-6 days ago. And today is Dr. Kitumba's birthday as well. So I think this is a special day for you, okay? Please,
thank you.
Jamel, give us your lecture on Chiari malformation.
Thank you. Thank you, Dr. Oscar. It's always a pleasure to be with you, even though distant. Thank you, Dr. Nasser, for the invitation to be part of this distinguished panel of speakers. And thank you, of course. And I please ignore any noise you hear in the background. It's because I'm still in the maternity, okay? So yeah, I'm going to speak very briefly about some aspects of the clinical and radiological criteria for diagnosis of Chiari malformations. As Dr. Oscar was introduced, I'm Jamel Kitumba. I'm an Angolan neurosurgeon, and my practice is based in Luanda, Angola. And as you can imagine, we also have a high prevalence of CVJ anomalies, and Chiari malformations are not an exception. So this is always a very interesting topic. Okay, I've got no conflict of interest regarding this talk. And Chiari malformations are congenital, generally a congenital, very heterogeneous group of disorders that are defined or characterized by different anatomic anomalies of posterior fossa, and subsequently its content is involved with different degree of cerebellar tonsillar herniation, some degree of or partial or complete absence of the cerebellum, and sometimes association with intracranial or extracranial defects. Some believe that Chiari malformations are also a result or in combination with inappropriate development of bony and neural elements. We have many cases that are symptomatic, but sometimes symptoms can appear as cluster as a syndromic fashion, with like foramen magnum compression syndrome, central cord syndrome, or cerebellar syndrome. And these symptoms or signals will be related to brainstem compression and or CSF flow impairment. So the first descriptions of these malformations comes from more than a century ago. And first there were identified 4 types of Chiari malformations, 1, 2, 3, and 4. And throughout the years, more subtypes have been identified because they do not fit entirely in the previous categories. And questions are pointed if they are really a continuum or if they are distinct entities. We are more to believe in the second part, because there are many different theories justifying why these subtypes of Chiari malformations appear, and they don't share all the same basis. For example, Chiari malformation type 1 is believed to be a paraxial mesodermal disorder that in conclusion or in result, we have a posterior cranial fossa. So this puts the posterior cranial fossa overcrowded and forces cerebral tonsils to herniate out of it. So the subsequent types of Chiari malformations have different bases to be produced. So let's start talking about Chiari malformation type 1. This is the least severe form of Chiari malformations, but also the most common. It is almost entirely congenital. There are some incidental cases and some post-traumatic cases of Chiari type 1. And Chiari type 1 is defined as an herniation of one or both cerebellar tonsils 5 or more millimeters below McRae's line, as we've seen in the previous presentation, this line, or even some authors accept 3 to 5 millimeters descent, but when it is associated with syringomelia or a peg-like appearance of the tonsil. As we've seen in the previous slides, this Chiari type 1 malformation is a result of a smaller posterior fossa. There are many studies proving that. We've seen that in the first life year, the cerebellum grows very quickly, and if we have a small posterior fossa, this rapid growing cerebellum is forced to grow into cervical spinal canal. Other modifications, anatomical modifications are present, like low tentorial insertion, occipital dysplasia, shorter clevis lange. All of this contributes to this cerebellum in part to grow outside of the posterior fossa. Also, not only the small posterior fossa is present, but also it is believed that a differential craniospinal pressure gradient across the foramen magnum contributes to this mechanism, producing an intermittent vector of force that is aggravated by Valsalva maneuver and thus creating a progressive downward of the developing cerebellum. Presentation is often in the adolescence or adulthood. Patients complain more of pain, different types of pain, but headache of any type is present almost in all cases of Chiari type 1 malformation. But we've seen like this many other publications. This is a very recent international consensus document, was produced and published last year, in which the more than 32 panelists agreed that for patients with Chiari will have almost entirely this complaint: headache, usually occipital or suboccipital, short duration, paroxysmical, and provoked or precipitated by cough or other Valsalva-like maneuvers. Other symptoms or signs of brainstem or cerebellar or cervical cord dysfunction, as Professor in the previous presentation always enlightened. Autoneurological symptoms and or signs like dizziness, disequilibrium, some sensation of alteration in ear pressure. These are very less common symptoms, but also present in patients with Chiari. And scoliosis, that is an optional criterion and not included in all cases of Chiari type 1. So headache is the principal symptom of Chiari malformations. We must be very aware of this. Patients come to our appointment complaining only of headache, this occipital headache, and that appears like very severe intensity and paroxysmal, occipital, suboccipital, accentuate or aggravates with Valsalva. This type of headache is very typical of Chiari malformation. So this consensus defined as clinical diagnostic criteria that including headache caused by A Chiari malformation type 1, defined radiologically, as we're going to see afterwards, and neurological symptoms and signs in relation to the brainstem, cerebellar or spinal cord dysfunction, as well as autoneurological deficits. So every patient that has two of these criteria are enough to define symptomatic Chiari. Not only Chiari, but symptomatic Chiari. This operational definition is very important for the treatment strategies. So imaging for Chiari malformations, not only Chiari type 1, but for all Chiari malformations is no doubt magnetic resonance imaging. MRI is the exam of choice to identify, to have sure the diagnosis, but also to characterize and identify all other abnormalities that can be associated with Chiari malformation. CT scan can also be used to identify the malformation, but it's not enough. It can be used also to characterize the bony anatomy of patients with this malformation. Some dynamic exams, flex extension X-ray, are useful to suspicion of instability of the TVJ is present. And also some others advocate the use of MRI with CSF dynamic flow study, and can be used to confirm the impediment of the CSF flow in the foramen magnum. So as you've seen in the first defining slide of this presentation, Chiari malformation type 1 is defined as a more than 5 millimeters descent of the cerebral tonsils below foramen magnum. If we use the limits of 3 to 5 millimeters, then a syrinx must be associated or a peg-like tonsillar profile to Chiari malformation type 1 be defined. So there are other subtypes of Chiari type 1. Maybe some authors advocate they are in the range of Chiari type 1 in severity or less or more severe than type 1. This Chiari type 0 is a malformation that we don't have hindbrain herniation. We don't have any part of the content of the posterior fossa herniated through the foramen magnum, but patients have an impediment of the CSF flow in this region and has syringomyelia or syringoidermyelia. And these patients also, for the definition to be assured of this diagnosis, they must improve after posterior cranial fossa decompression. So other features of this malformation are that the tips of the obices are more than 2 deviations below normal position at foramen magnum. Anterior-posterior mid-sagittal distance of the spinomedullary junction was increased, and the angle between clivus and fourth ventricular floor was increased. And in terms of clinical presentation, they do not differ so much from the Chiari type 1. They share a similar pathophysiology, and so the complaints are also very similar. The Chiari type 1.5 is considered an advanced form of Chiari malformation type 1. Here it's more easy to identify an herniation superior or more than 5 millimeters, but not only the cerebellar tonsils are herniated, but also a caudal descent of the brainstem through the foramen magnum is present. These patients often have syringomyelia, hydrocephalus, and this considered complex if some skeletal disorders are present, like Kupperfeld syndrome, atlas assimilation, and others. Chiari type 2 is a different subtype of Chiari malformation. In here, it's not the small posterior fossa that causes this type of malformation, but some believe that is the CSF hypotension that causes this. And not only the herniated tonsils are present, but also the vernage. We find some elongation of the pons in fourth ventricle, and it's virtually present in all cases a myelomeningocele, distant myelomeningocele. This other feature that could be present with Chiari type 2, some supratentorial and other infratentorial anomalies. And these patients have some more prominent clinical presentation, more severe, There are some cases with great disability. They present earlier in life, different from Chiari type 1. Chiari type 2, type 3 is very rare form of Chiari malformation. In here we have this occipital or high cervical meningoencephalocele in every cases, in which we have part of the hindbrain in its content and liquid TSF. We can have some part of cerebellum with or without brainstem in the encephalocele. Chiari type 4 is nowadays an obsolete term, but when it was not considered obsolete, it was already controversial and very extreme rare variant, in which it was characterized by severe cerebellar hypoplasia. Some discussion whether encephalocele was present or not. In the original description of Hans Chiari, an encephalocele had to be present. And unfortunately, most of these patients do not survive infancy, and it's not considered a form of hindbrain herniation. Then some authors have published recently some cases that do not fit also in the previous categories. This is a type 5 Chiari. I don't know if it's already consensual, but it's very rare, very severe, present with cerebellar genesis, but this patient have an encephalocele, occipital encephalocele. In this content, you don't have cerebellum because cerebellum does not exist or is very hypoplasic. You have occipital lobe herniated through the encephalocele. This is just a catch-up of what we've talked. So in summary, we have Chiari type 0, where you find syringomelia without hindbrain herniation. A Chiari type 1, where the remarks is the peg-like cerebellar tonsil herniation more than 5 millimeters herniated below foramen magnum. Cerebellar tonsils more brainstem herniation type in 1.5. Cerebellar tonsil more vermis brainstem more myelomeningocele, distant myelomeningocele in type 2 is what characterizes this type of Chiari malformation. Type 3, where we have the encephalocele, or high cervical encephalocele. And type 4, rarest form of all of them, when you can find the cerebellum hypoplasia, more occipital encephalocele. This is going in disuse. This is very rare. So Chiari malformations are a complex group of congenital diseases with different degrees of hindbrain herniation with or without associated intracranial or extracranial anomalies. We find 4 classic categories of Chiari malformations and some subtypes, variants of these malformations. The clinical pattern and radiological findings are mandatory for diagnosis and treatment strategy. Thank you very much.
Thank you, Jamel. It was really an outstanding presentation, very good overview. So now we were supposed to have Professor Said Ben Ali from Morocco, but that was a last-minute dropout. So reason I invited a world expert on craniovertebral junction, my friend Professor Dantas from Brazil, from Belo Horizonte. And only he could do this talk in less than 12 hours. Fernando, we are very grateful to you for rescue us, and please talk us about the surgical indications for Chiari, which Chiari patients we should operate. You can share your screen now.
Okay, thank you, Oscar.
Screen mode. Yes.
Okay.
Perfect.
Okay.
Perfect.
Good morning. Thank you, Oscar, for the invitation to participate in the meeting. Today, I'm going to talk about the natural history criteria for surgical treatment of the Chiari type 1. You know the definition of the Chiari made by Miller in 1999 correspond to underdevelopment of posterior cranial fossa and overgrowing of the normally development hindbrain, but you can easily the radiological criteria for the diagnostic Chiari, like you can see here, the normal position of the cerebellar tonsillus, and the Chiari definition, the 5 millimeters below the foramen magnum. Of course, this is a radiological criteria for diagnosis of the Chiari type 1. You have published the papers regarding the natural history adult type 1 Chiari, which will be the base for this class of course. Regarding the conservative treatment of Chiari, they are the main criteria used. You can see here. Number 1, no neurological, physiological deterioration, without progressive posterior fossa or spinal canal symptoms, signs, or hydrocephalus. Of course, patient asymptomatic with or without syringomyelia. Patient with moderate symptoms should be accompanied by MRI because it's very, very hard, the acute deteriorations. You can see here one resolution, complete resolution spontaneous of the Chiari malformation. You can see here, but it is very, very hard in the literature. The natural history of the Chiari demonstrates that there are few reports cases of a spontaneous resolution of the Chiari malformation. There were the main criteria for surgical indication. You can see here the presence of the Cook headache, number 1, negative impact of the quality of the life, large or growing syringomyelia, neurologic deficit, and anomalies of MRI dynamics with the flow, severe sleep-related breathing disorder, of course, and cranial nerve dysfunction, of course. The very important, the radiologic diagnostics, no definitive or consistent relief images predict where identified to prospective decide which the patients will be benefit the most from on surgical indication. In relationship, the Cook headache, the 40% of the patient improve the symptoms following the conservative treatment. Very important, other kind of the headache, like a frontal headache or migraine headaches, 6% of the patient improved with the conservative treatment. Though, just remember, the surgical indication for only Cook headache, the migraine or headache frontal is the conservative treatment, it's better. The effect of the surgery in headaches is the different. You can see here, about 40% of the cases which the Cook headaches improve with the surgical treatment. Most of 50% of the patient not changing the clinical with the headache with the surgery. And about 10% of the patient can be worsened the clinical with the treatment surgical. Another thing very important, we talk about the severe sleep-related breathing disorders. It is having high prevalence. So, nocturnal polysomnography record should be systematically conducted, especially in this patient, male, older, and patient obese or overweight. Another thing very important, talk about the brain stem auditorial and somatosensorial evoked potential. About 7% of the patient with Chiari malformation type 1 show some alteration in this exam. So the very important screen tests, especially in patients with few or no symptoms. So it can be used the text, the exam for diagnostic of the following the patient with Chiari malformation type 1. Another thing very important, relationship the Chiari malformation and sportive practice. What do you think about this? Which the patient can be removed with Chiari malformation in the activity sportiva? Number 1, presence of the syringomyelia. Number 2, obliteration or subarachnoidal spacing. Number 3, evidence of indentation of the anterior spinal cord. And finally, number 4, presence of the symptoms that can be explained by obstruction of the CS flow. You can see it's very, very hard, the deterioration, the acute deterioration following the trauma. Only 8 cases involve adult patients, deterioration following the patient. In the only cases, 2 cases, it submits the surgery because they have the acute deterioration. Another thing very important, no restriction associated with the participation of asymptomatic patient with Chiari type 1 without sirigmelia in contact sport. Of course, the patient without sirigmelia should be discussed with the patient in the family, of course, but it's not a contraindication to practice sport. Another thing very important in the MRI, which is study of the flow. And 2 things, strong positive correlation and negative correlation. The strong correlation is the main accidental stroke volume. More or than 16, it's very good positive correlation with the indication of surgical. The negative correlation, long symptoms in duration, sleep apnea more than 2, presence of the pterigmelia, the herniated ectopia of the coronal sequence, a stroke acute less 15 millimeters. Of course, the treatment of the Chiari malformation associated with or without pterigmelia is very, very controversial. The treatment of the Chiari malformation type 1 without pterigmelia, asymptomatic patients, is very controversial in the literature. It's most trained a favor for conservative treatment option, of course, accompanied with clinical radiological monitoring by MRI frequently. Deterioration acute of adult patients is very, very hard with pterigmelia, less 5% of the patient. Another thing very important, the bearing outcome following the surgery in the patients, pterigmelia, compared to the patient with pterigmelia, of course. The patient with pterigmelia, it's bad outcome following the surgery relationship with patient without pterigmelia. You can see resolution spontaneous, the pterigmelia with the conservative treatment. It's very, very hard in the literature. You can find about 16 patients in the literature with the resolution spontaneous of the pterigmelia with the conservative treatment. Recently, on consensus of the Chiari malformation, you can describe the conference about the surgical indication and follow-up of the patient. Number 1, in symptomatic patient Chiari malformation type 1 without pterigmelia, surgical indicated in the patient with Cook-Hideki typical and brainstem potential evocado positive. In patient Chiari malformation type 1 asymptomatic without pterigmelia, the surgery is not indicated. You can see here. The number 3, in asymptomatic patient Chiari malformation without pterigmelia, of course, the follow-up is mandatory with MRI for the follow-up. If number 4, Chiari malformation with pterigmelia, surgery is indicated in the patient with pterigmelia, MRI clinical, of course. The patient, asymptomatic patient with Chiari malformation with pterigmelia, of course, the brainstem potential evocado may be performed to evidence the subclinical deficit. So you demonstrate 17% of the patient have the alteration index exam. And to conclude, the World Federation of Neurosurgery Committee concludes, number 1, the natural history of patient of asymptomatic Chiari malformation type 1 reveal favorable evolution. Number 2, the patient diagnosed with asymptomatic Chiari malformation or with middle symptom may improve over the time with conservative treatment. Number 3, the patient with asymptomatic Chiari malformation type 1 and pterigmelia should be treated conservative and accompanied followed by clinical radiologic monitoring, of course. Number 4, patient with malformation Chiari type 1 should be submitted MRI with dynamic study of the flow. Asymptomatic patient with Chiari malformation type 1 without sirigmelia should undergo somatosensory potential evocation and polysonography. Such indication should be considered in patients with severe sleep-related brain disorder and Cook headache. And finally, the patient with Chiari malformation type 1 are asymptomatic or who have no sign of sirigmelia, no restriction required for the participation in contact sports. So thank you for your attention. Thank you, Oscar.
Thank you, Fernando. If I have seen better, I can't remember. You prepared this lecture in 12 hours. This is amazing.
I did try to my best. I'm sorry.
You are very good. You are very good. So we have some questions here, but they are mainly related with surgical techniques. And probably we should go now for the surgical techniques, the different surgical techniques to treat Chiari malformation, and then we go and do the discussion of the whole presentations. So to present on how to perform decompressive surgery for Chiari malformation, I call my dear friend from Saudi Arabia, Jeddah, Professor Saleh Baiza is the head of neurosurgery. He's a very fine worldwide educator, and I'm sure he will deliver a very interesting topic. Professor,
thank you very much, Professor Alves, and thank you very much, Professor El-Ghandour, for this nice webinars. I'm very happy to join the 70s.
Thank you.
These are very great educational webinars. I enjoyed a lot over the last 2 years.
Thank you.
I'm going to take you through how the decompressive craniotomy done for Chiari malformation. This is not what I do it all the time, but I've learned many from over the last 20 years, and I learned it from many colleagues, and I kept modifying my approach. We know the first decompression was done for Chiari. It was for Chiari type 2 in 1920.
Sorry to interrupt you.
Yes.
Just put on the screen mode, please.
Screen mode.
On the bottom right, probably. It will be easier for us.
Is this okay now?
Not yet. On the right side, you should have the screen.
Let me stop again and share it.
Yes, perfect.
Okay. All right. So the first case decompressed was a long time ago by Cornelis Jacquemus van Housen. He decompressed the Chiari type 2 patient with myelomeningocele, and if you read his objectives, it's the same objectives that we are trying to achieve, which is widen the space to allow CSF flow. Now, we heard a very great 3 speakers talking about the introduction for the Chiari, and I have to emphasize that patient selection as a surgeon is very important, and it should be done by the surgeon. You should not operate on somebody with chronic headache, as Professor Santos nicely explained. You really have to treat other lesions like hydrocephalus and tether cord before. You have to remember that there are some conditions like spontaneous intracranial hypotension has different clinical presentation, but it might have different MRI features. Benign intracranial hypertension, it can happen with some tonsillar herniation with papilledema. So all this should be not operated as a Chiari. Also, if you want to operate on a Chiari, make sure you don't do only decompression alone for someone has a complex craniovertebral junction anomalies or deformity that require fixation. Now, my talk will be decompression, usually for type 1 and type 1.5 cardiac malformation that was explained nicely by Dr. Jamal. This is a classic case of a young patient with severe suboccipital headache, Valsalva induced, with blackout many times. She has difficulty swallowing and shocking attacks. She has sleep apnea. So she has a classic neurological presentation of Chiari. Always you have to do the sagittal MRI for the whole spine. This is a Chiari protocol, looking for a syrinx. I always do also vascular imaging, make sure, especially for the vertebral artery, this patient has no vertebral artery in the other side. So if you want to remove the C1 lamina, you should be very carefully on the only one vertebral artery in the side. You have to remember there are many sinuses anomaly in Chiari malformation, and sometimes you have downward, even in the midline of a big sinus. You have to know it in advance before you have any catastrophic injury. My talk will be talking about this list: the position, exposure, how much decompression you do, dural opening, what do you do next, what do you do about the tonsils, and then how do you close. Position is very important, and I don't use a horseshoe. I always fix them in 3-pin Mayfield clamp in prone or concord position. You try to keep the neck in a neutral position, although you can allow some mild flexion. Many people are afraid from too much neck flexion with it can cause spinal cord injury. There is a systematic review published in the World Neurosurgery, and they found some cases of spinal cord injury from positioning in a prone, and only 2 cases were due to was operated for Chiari malformation. I'm sure there are many numbers not published, but this you have to be careful with it. I like to put them on Wilson frame with the shoulder lift up a little bit to have the patient comfort and elevated. Some people like to do a sitting position for posterior fossa. If you have a good setup in your hospital, this is nicely done. The air embolism is not as overemphasized. It's about up to 3% in those cases. Intraoperative monitoring is something good to have, and for a standard decompression, I don't do it unless there is some craniovertebral junction abnormality that I require to do fixation. So exposure, always start to and stay in the midline, as everybody mentioned that. You have to be just above the inion into the C2 spinous process. Avoid going laterally to get the greater occipital nerve. This can be injured by the dissection, by the cautery, or during closure of the muscle. So be careful. This can give the patient significant morbidity with the occipital neuralgia. Subperiosteal dissection, I use the cautery. You can use the periosteum for those cases. Do your exposure. You don't have to expose significantly large suboccipital bone. Usually 3 to 4 centimeters is enough above the foramen of magnum. I always expose C1 lamina. Be careful with the vertebral artery variations, which can be numerous in craniovertebral junction. And always be careful when you use the cautery. Now, once you have your exposure done, before doing the bone work and decompression, I like to dissect the foramen magnum from the fibrous attachment and the dura, and the same for C1, C2, because if you don't do that, when you do the bone work, you might injure the dura and the ligament, and you can cause premature opening of the dura. Craniotomy, I always do my craniotomy for posterior fossa, except Chiari malformation. These are very tight posterior fossa, and there's a chance of additional injury for a very tight place. Beside dural laceration can happen, so I do craniotomies. You can do it by thinning the bone and then making small burr holes and start doing suboccipital craniectomies. Using a small Carrison. Do the suboccipital bone first and walk from the up down to decompress the foramen magnum, and then C1. As I mentioned, as you can see here, I measure around 3 centimeters from the foramen of magnum and less than 4 centimeters. If I have a patient with very tight posterior fossa with syringomyelia, I like to do slightly bigger decompression. In the past days, they used to do like a sigmoid to sigmoid decompression up to the straight sinus. This is not good, and it's not done anymore. There is a significant problem and morbidity with that. It can cause cerebellar sagging or ptosis with this. C1 laminectomy is controversial in a low-lying tonsil. I always take it out, and it's simple, straightforward, and it has no additional value if you leave it or you keep it. Of course, if you have Chiari 1.5 or there is a syringomalia, you should take out C1 lamina. I never took C2 in these cases. Usually C1 is enough. And how to do it? Sometimes the C1 lamina is very thin. You can do en bloc osteotomy with a craniotome from both sides carefully, and you take it en bloc. Sometimes it's very thick and wide. You have to be careful. You do microscopic drilling of the outer cortex, and then you take it with a small kerosene. This is after removal. This is a bed hole here in both sides, and then here there's a big the osteoligamentous junction. The C1 lamina here was removed in this patient, and this is a post-operative scan. Just want to show you how much usually bone is removed. This is for a patient with syringomyelia, and this is at the foramen magnum here. You don't have to take the medial part of the condyle. This is good enough. 1.5 centimeter is very good decompression, and this is C1 decompression here. And this is 3D reconstruction. You can see a removal of C1, and this is a nice and usually enough decompression for Chiari malformation. In some cases, some people, this is controversial. Some people will do only bony decompression and cutting the ligament, and usually this will be enough, especially in patients with non-neurological signs or significant symptoms. Those patients usually they have the classic Chiari headache. In pediatric population, it can be done, but not adults. Patient with syringomyelia, it's not advised to do only osteoligamentous decompression. You have to open the dura. And if you want to do that, you want to be doing a selective. You really have to learn how to do ultrasound, or get someone to show you the ultrasound. It's a very beautiful images you can get after decompression. The dural opening, there are many ways of doing the dura. I like the Y-shaped here and going down, and then another Y-shaped small down here at the C1. I like to reflect it up and down and sideways, and usually start lateral as much as you can. Sometimes there's a venous small sinus here. You have to be careful. You can use bipolar. You can use the hemoclip, and then you open the top, and then you can continue with the midline opening of the dura, and then continue with the small Y below. Once you're done, you need to anchor or stitch the dura to the side, so avoid getting blood spillage into the surgery. You don't want to get blood, because this will give your patient chemical meningitis and severe headache and maybe adhesions. What do you do intradural once you open? In some cases where there is no significant tonsillar descent or compression, and it's not very bulky, arachnoid membrane, in some cases, some surgeons like to leave it like this, and it's pulsating nicely. You can go ahead and finish and do your dural repair. Or a duroplasty, and sometimes you can coagulate a little bit from outside, but this is in cases where you don't want to violate the arachnoid. In some cases, like this patient here, it's important to open the arachnoid. You can open it in the midline. You can excise it. You can lift it and hold it with the hemoclip to the dura, so you can include in the closure. There is a strong evidence nowadays coagulating the tonsils and lifting up the tonsil away from the foramen magnum is associated with a very good decompression and very good resolution of the symptoms and syringomyelia. So this is done. And the way to do it, you can do by irrigating bipolar under the microscope, start dorsally and medially here. Of course, you have to be careful of the pica branches, you have to do micro dissection. And I usually coagulate until I see the opex and I see the fourth ventricle. You have CSF flow coming out from there, and you stop. In cases, sometimes you have a very large and bulky tonsils, and in these cases, I do subpial resection of the tonsil. In some cases, I've seen there's a bulky brainstem blib. It's like it looks like a tonsil, but if you really dissect carefully, you find this is just a kinked brainstem, and this is where you have to be careful not to start very quickly and coagulate and shrink it. You might be working on the brainstem. So this is a very rare abnormality. You really have to be careful. And if you are not sure, don't coagulate the tonsils. What do you do in patient with syringomalia after you have done the intradural dissection? I always leave the syrinx alone and disturb the majority, up to 90%. With time, they have clinical and radiological improvement with MRI after 3 or 6 months. There are some exceptions. If this is a redo case, definitely I would work on finding the syrinx and decompress it, putting a tube and put it caudally into the cistern. If the patient had a significant extensive syrinx and syringopalbia, you want to really think of going safely and making a small opening and putting a tube and divert the syringomalia in those cases. And even I've seen big syrinx that deflated while you do the surgery once you coagulate the tonsils and open the fourth ventricle and communicate the CSF. So just my advice is not to do anything except in few exceptions. Now, the dura graft, I always do duroplasty in low and mid income countries. You have a very nice autologous graft precranial. You can extend your incision and make sure you prepare it early during the exposure. You can use a fascia lata, bovine. This is what I do on most of the time. Gore-Tex is a very nice patch, but you have to use the suture. The Gore-Tex suture is very wide. Their needle is small. If you use the Prolene suture with the Gore-Tex, you're going to have a big hole, which all of them, they're going to leak. So if you really want to use Gore-Tex, although it's expensive, use their suture. I don't like synthetic Duragen closure. These are nice sutures for skull base, for supratentorial closure of the skull, of the dural defects. It causes a lot of scarring and a lot of inflammatory and adhesions. So I like the the other one, the bovine or the Gore-Tex is available. And I use the 5-0 Prolene continuous. And you practice the same as you're doing endarterectomy, as if you are closing the vessel. You really have to take your time, suture by suture, and lay down the suture down and go and keep going with this. I like to anchor, after I finish, anchor the dura to the side, to the muscles. I like to tint up the dura to give more space. Some cases where the dura will fold in and it can cause adhesion. So this is a nice technique I've learned. You know, the best thing is to do a good closure. You can use, after I finish, I always wash with vancomycin containing solution. Sometimes I like the putting fibrin glue. It makes you comfortable and feel, you know, you have this good feeling from inside. I don't think it adds a lot if you do a good closure. Sometimes I put only either synthetic dura, which adhere very nicely in a very thin patient with thin dura that I'm not happy with my repair. I want to support it. You can apply Tacocil or Hemopatch. I don't like cranioplasty. Some people have replaced part of the bone in the upper part of the craniectomy and fix it with a plate. Some people have put a mesh in the upper part. The reason for that, they believe that the adhesions with the muscle to the dura can cause severe neck pain, which have seen this, but I don't have experience with cranioplasty. I don't put drain. If you have oozing, you really have to stop it. This is a very dry surgery. You go in very carefully and you come out very carefully in these cases. And the muscle closure, you know, I've seen people close the muscle with big bites. this is not going to give you a watertight. The muscle just approximated with suture, 1 or 2 layer is enough. And I usually reconnect the muscle where I remove it from the superior nuchal line. I put suture or mini plate and reconnect it there. But you really have to get the patient back in extension a little bit so you can easily close the muscle, subcutaneous, and then I always close with vertical mattress, absorbable suture for skin. Now, this is a brief presentation, but decompression is a straightforward surgery. It has a good outcome. It has a high complication if it was not done properly. It is important to get the right operation, and usually the first operation is the best for the patient. There are basic and simple technique that everybody will do in decompression. There are some modification you can do. If there is a syrinx, if there is a large tonsils, you have to learn all this, and especially if there is a complex anomaly at the junction. Complication, acceptable complication like infection and pseudomeningocele, which is less than 5% in most of the surgeon hand. These are acceptable, and it can happen. There are there's no shame of having one once in a while. But there are unacceptable complications like brainstem injury. These are straightforward, beautiful surgery, and should be done by a well-trained surgeon. Not everybody are doing this. And the closure is one of the important part of the surgery. Should not be left for the junior and should not be rushed quickly to have the second case. Now, there is a new evolving technique. I'm not going to talk about it, but it came from China and your groups. They're talking about a very minimal small incision of about midline 3 centimeter, where you remove the posterior part of the foramen magnum and midline incision in the dura, and you do decompression with subperioral resection of the tonsils, and they have shown really very low complication and very good outcome. And with that, I would close. And again, thank you very much for having me in.
Thank you, Professor Saleh. It was really an amazing lecture, and we learn a lot of tips and tricks from very experienced, very top surgeon. Now we open, before Ricardo gives his lecture, we open a bit for discussion. I see some questions here from Dr. Danny Halim, Dr. Hashad Harek, and they are very concerned about the association of Chiari malformation with syringomyelia. So they are asking if you do always duroplasty, or in some cases foramen magnum decompression can be enough. And this is an open question for all the previous speakers, including Professor Monem. Saleh, please. Do you do always duroplasty in your syringomyelia cases, or you believe that foramen magnum decompression is enough because syringomyelia is a result of CSF obstruction flow?
Yeah, that's a good question, and I think we talked about this one through the consensus conference. It was done last year, and from my review in this subject, there is a strong evidence that decompression alone for a patient with syringomyelia does not give you, it gives the same short-term outcome. Let's be honest with the people who did this work. They have good short-term outcome, but later on the long-term outcome is not good. There's significant recurrence and the reoperation rate is there. So a patient with syringomyelia, I will open always the dura and do the intradural work, and I will do duroplasty.
And putting the tube to drain the syrinx is really something, an exceptional surgery, right? This is the message to convey.
I agree. Unless you see the syrinx going all the way to C1 and even to the brainstem, and you see a bluish discoloration, very thin membrane, it's there. And if you feel comfortable with that, you can if you have a monitor, you can do that. You can do small incision and put the tube inside the syrinx and then pass it cephalad to the cistern. I've done that cases, but in cases where you don't see the bluish discoloration, the syrinx is there, and you have to go through the spinal cord, I would not do that. And because we know from the published report, there is leaving the syrinx the majority. It's not, they used to say 70%, and I think there is a recent report going up to 90% of a good clinical and radiological improvement of syringomyelia.
Okay, Professor
Yes,
Menem, you want to add something?
Yeah, yes. Just this will be finally detected by the pathogenesis of this syringomyelia. If this syringomyelia developed secondary to CSF obstruction and disturbance in the circulation of CSF by this compression through the chiarimal formation, so after release of this compression, expected for this syringomyelia to release, because it is just secondary problem from the primary one. So this is what Dr. Saleh is explaining now. The improvement will come from this mechanism, because the syringomyelia is just secondary effect of the obstruction and CSF disturbance of circulation. Once you treat the primary problem, the secondary problem expected to resolve spontaneously. But if the syringomyelia is separate issue, it is separate entity, so it must be dealt with separately. I think this is the point.
Thank you, thank you. You know, we have here a very quick, again, another question from Ali Bayati. What is the most important surgical step to prevent recurrence in this kind of surgery? And of course, this enchains on one question that I want to ask you, Saleh, which is how much are you concerned on going lateral, almost to the condyle, to get also a lateral decompression? Because my feeling is a lot of osteoligamentar decompressions fail also in the long run, because surgeons tend to do really a small midline decompression. And I think you should go as far as lateral to the condyles you need to have also not only on the posterior to the cord CSF, but on the lateral of the cord. And this is something that you can see on postoperative MRIs when you do a really good anterolateral decompression.
Yeah, I agree with you. I think the adequate bony decompression, especially at foramen magnum, is the key. In some cases where you can see the condyle coming closely to the midline, I think even taking some medial part with the drill under the microscope of the condyle, not more than 30% in each side, it should be fine. Does not destabilize the spine. I think this will add. You know, I feel comfortable once I see the edge of the spinal cord in both sides. I think that's enough. If you open the dura and you don't see the spinal cord here, it means that you really have to go lateral. So this is something that you really have to keep going back and forth and make sure you're doing decompression. And I agree, you know, I have to review the literature about what is the optimal bony decompression for suboccipital bone. We don't know. There's no evidence, but the majority will say around 3 to 4 centimeter there. And I think this is maybe the right answer that everybody in his practice what he's doing.
And Saleh, do you think, very quick answer before we go to Ricardo Gap, if you choose not to do a duroplasty, just ligamentar decompression, is it fundamental to have ultrasound to check on CSF flow behind the spinal cord, or you don't need it?
Yeah, I think so. I've operated on a few cases done by my colleagues, and I found very interesting. They have a thickened arachnoid web at that area from long time compression, and it stay there even after. If we remove the ligament from outside, it from outside looks nice, and the dura came out a little bit. But if you really have to do ultrasound, and you have to see the pulsations, and our radiologists, they have very good experience, and they show us, and we learn from some courses how to do ultrasound and the good movement of CSF and pulsation around. And you can do it before you remove the ligament. It's nice to do it before, just to have a visual how it looks like. So you can appreciate after removing the ligament how it looks like. But again, because of a few redos I've done and I found this ligament, I still feel, you know, without ultrasound, I don't think you really have confidence of what you have done. think you might have problem or incomplete. You might get away with this in some cases, but you might not have a strong evidence coming from the OR that you have done adequate decompression.
Right. Thank you. Thank you. I invite you also to go to the chat and answer some of the questions that we have there. We have questions about C1, C2 fixation, the GOEL advice for Chiari. I think this should be another webinar, so I'm not opening this question, and I go really to Ricardo. Ricardo Gap is our next guest. Is from Brasilia, from Brazil. He's an eminent pediatric neurosurgeon, probably one of the best or the best in Brazil, very huge experience. And he will talk us about the pediatric Chiari malformation with associated syringomyelia. Please, Ricardo, it's our pleasure to have you here.
Thank you, Oscar. Thank you so much for this kind invitation. Good morning, dear friends here in Brazil, but I think for all of you is good afternoon.
Can you share your screen, please?
Yeah. Can you see my screen?
Yes, just put it on screen mode, and it will be fine.
So I will talk about
yes, perfect. Perfect.
Yeah. I will talk about Chiari malformation, especially in pediatric population. So in this lecture, I will talk about some objectives and some practical management, and of course, do a huge review of the literature. This is a phrase from my mentor, Dr. Leland Albright, a famous pediatric surgeon, that the tightness of the foramen magnum is more important than the tonsillar herniation, especially in kids, okay? But you have a lot of doubts when I deal this problem in children, because the presentation in children could be very different. Children have some difficulty to talk about the problems. The fathers are so worried, and you have to be careful in some cases, especially. But I put here some doubts that we discussed last year, but for me, it's very important doubts when you deal with this problem in children. The first one is about scoliosis. Of course, if you have scoliosis and Chiari 1 with syringomyelia, of course, the surgery will be indicated, but the surgery alone, you avoid the scoliosis progress. This is a very important doubt in literature. The second question, if you find a scoliosis with Chiari 1 without syringomyelia, the surgery could be indication to avoid the scoliosis progress. This is a second important question. Another question that was discussed by my friends before me is if Chiari 1 could be treated only with osteodural decompression without duroplasty. This is a very important question in children. And you have some special issues in children, like if you have Chiari 1 and craniosynostosis, what the best way to treat these patients? And if children with Chiari could play sports, this is a very common question made by families. But you have to understand that Chiari 1 could be only a image presentation. There is a lot of studies, and I can talk more about this study from Professor Di Hoppo from home, that they find 50% of the patients are incidental findings when they search for the treatment. So this is very important. In this incidental patients, only 22% have clinical worsening. This is an important number to put in mind when you see a child with Chiari 1 only in an MRI. This is very common in my practice. A lot of parents coming to see me only with an MRI. Oh, my kid did this MRI because he had a head trauma, or a small head trauma, or is not going well in the school, and I did the MRI and I find this Chiari 1. This is very important because probably only a few patients will get worse in the future. This is a very important study published in New England Journal of Medicine about incidental findings in normal persons, and Chiari-1 could be found in almost 1% of the population. So this is another very important number to put in your mind to understand how to deal with these patients. There are a lot of the studies talking the same situations. This is very interesting because only a few of these incidental findings will get worse when you can see in this very important paper made by Duhan and published in Journal of Neurosurgery Pediatrics. So, but this is different if you find syringomyelia. Syringomyelia is a CF disturbance. So if you find that, you have to operate Chiari. I think most of neurosurgeons will indicate the surgery. But what about the outcomes? This is a very interesting meta-analysis was published in Child Nervous System, the association of Chiari-1 and scoliosis, and about the intervention. So after surgical intervention, the magnitude of the curve improved only in 37% of the patients. So this patient could be operated again for the scoliosis, but you have to take in mind that if you have a very early scoliosis, your surgery could be keep this curve in a good situation. In only a few patients will improve only with your surgery to decompress the Chiari. So this is a very interesting meta-analysis to discuss with your orthopedic teams who treat the scoliosis. But of course, the Chiari surgery will be necessary. This is a very interesting group, the Park River Syringomyelia Research Consortium. This is a consortium that only study Chiari and Syringomyelia in pediatric patients. And they study about the association of Chiari malformation and spinal syringomyelia and scoliosis. And the conclusion of this very interesting study, this is a prospective and retrospective study with a lot of groups in the United States. They concluded that the syrinx is the most important situation to indicate the surgery because the patient with syrinx has a good chance to increase the curve of the scoliosis. So if you have a patient, a child with syringomyelia and a few symptoms, but the scoliosis is a symptom, you have to operate this guy, these children, because the chance for the increase the curve is very high. So if you have a patient, so you have a lot of options of the treatment for treating Chiari. One, bone decompression only, incise only the dura, open the dura, leave the dura open with the arachnoid intact, duroplasty of materials, open the fourth ventricle. There is a lot of options. So what's the best way to treat the patients? The ISPN, the International Society of Pediatric Neurosurgery, did one survey to understand the opinion of neurosurgeons around the world. This is very interesting because the first survey was made in 2003, and they find that most of neurosurgeons always open the dura. It's very interesting. They did the same survey in 2016, and the number of the neurosurgeons who only open the bone or they compress only the bone is increasing. Why is happening? Probably because the number of the complications is more if you open the dura. And the great question is this an overkill to treat the children? Remember that I'm talking only about kids now. So if you can achieve a good decompression if you only do an extradural operation, this is very interesting because you have a lot of different papers doing good results for each options of the treatment. But it's very clear if you do only the bone decompression, the number of the complications is decreases lesser if you open the dura. And some very good studies like this published by the group of the Professor Sutton showing that the results could be very, very similar if you do this in kids, especially in kids. If you look to this graph, the symptoms resolution was very similar in those groups. And the syringomyelia will be decrease. This is very similar também also in these two groups. There is different studies showing best results for only the decompression, bone decompression, and another study showing good results if you open the dura. If you have same results, what is the conclusion about the best technique in childhood? The meta-analysis saying that the situation is very similar. This meta-analysis published a number of 500 patients and showing that the clinical improvement could be better if you open the dura mater, but the number of the complications will increase. So I think if you are dealing with a special kid, if it's syringomyelia, if you carry one malformation, you have to know exactly what's the number of your group, what's the number of your patients, especially the situation of you are dealing with this patient, because of course each country has different situations. Here in Brazil, we have patients who come to us for a very long distance. So maybe in this kind of patients, you can do a minor surgery. If you have an hyperactive child with very difficult disturb of behavior, probably a small surgery could be enough for this child. This is only a thing to you have to think because about your numbers before decide what you have to do. Another meta-analysis showing that no duroplasty could be good, but this is very important, complications for me, because if you do a surgery and the patient has a CSF leak, most of the patients will have infection, pseudomeningoceles, meningitis, subdural hematoma, and hydrocephalus is very common as a complication in some of these patients. Know your complications, but if you have literature doing good results for open the dura or not open the dura, you still have a problem in literature. So this group from Washington University did a prospective study comparing posterior fossa decompression with or without duroplasty. This is a very interesting study because there's a lot of centers in the United States, and this is a prospective study. And there are the inclusion criteria for these patients, and the inclusion criteria, you can see here, the age is only in child patients, and they did a very interesting study. And the conclusion for this special group, and this is a very important group, this is a prospective study, that the duroplasty is more interesting, is more efficient for treating the syringomyelia. I think it's a very important study, but I really think that you have to know exactly your numbers to decide in your country what you have to do or not. The second question for me, it's very important, is what about sports in kids? Sports is very important now, I think, in all the countries. Here, the soccer, the football in Brazil, but in other countries, we have very intensive sports. And the families ask it so frequently about if you have to avoid or not the child to play sports. There is any good data about this? Physical restrictions is very difficult for child and sometimes can move to emotional problems the patients. But the ISPN did another different survey to understand about the restrictions. And in pediatric population, more than 45% of neurosurgeons do any kind of restrictions, but small restrictions to play sports, and 20% of neurosurgeons completed for forbidding the child to play sports. But there is any data for this? No, there is no data for this. This is another very good study published by Australia, showing that in a very large population of patients with chiari-1 malformation, only one patient had a transient numbness after falling during playing soccer. So if you don't have data, why you are avoiding the child to play sports it's a very good question. Of course, if you have syringomyelia, the probability of a large problem could be increased, but there is no data about only syringomyelia in these patients. So the literature did, Spencer did another review and published in British Medical Journal, and they found only 21 cases of the patient deteriorated after trauma playing any sports. So the risk is very low to the child to play any kind of sports. Another different situation, especially in pediatric neurosurgery, is the association of craniosynostosis and Chiari-1 malformation. This is a very difficult situation because it's not only a posterior fossa problem, you have a completely cranial problem. So in these patients, you can use in some special situation, the posterior vault decompression and the expansion with distraction. This is a very interesting issue. It's a very uncommon, but you can use this. And if you do a decompression, like you can see in this picture, you can see here the signs of hypertension, intracranial hypertension after a posterior decompression. It's not a posterior fossa decompression, but it's a calvarium fossa decompression. The pressure will decrease and the Chiari will improve. This is a very interesting study showing that the action of the decompression and the external expansion. You can see here how the cranial expansion could be very interesting, and you see that the Chiari-1 improved after the surgery of the cranial valve decompression this distraction. It's a very uncommon situation, but the neurosurgeons will deal with the child could be in front of this kind of situation. So posterior vault decompression, so it's only case reports and case series, only especially in pediatric centers you can see this kind of patient, but taking in your mind that it could be necessary not only the posterior fossa decompression, but all the calvarium decompression with the expansion and distraction. Of course, it's very expensive, but it could be a very good opportunity to treat these patients. So my personal conclusion, it's very personal, but I based it in all the literature that I showed for you. I can say that the surgery, especially in patients with Chiari-1 with syringomyelia, must be indicated. Craniovertebral junction decompression, only decompression without neuroplasty, I think it could be an option if you have difficult patients, especially children with behavioral problems. I indicated patients come to me from a very long distance. I could use it, but of course, neuroplasty has better results if you compare only if osseous decompression. Another situation, if you see a Chiari-1 without syringomyelia scoliosis, could be an indication for surgery only if you have look for any other problems. If you don't find any spinal cord tumor, if you don't find any tetracord problems, if you don't have any other problems, could be an option. Treat the Chiari-1 if it's scoliosis, without syringomyelia, could be an option of treatment. The cranial vault expansion is recommended only in patients with Chiari malformation associated with craniosynostosis. And of course, children with Chiari type 1 can play sports because the risk is very low, and only patients with large shrinking area, you can talk with the family to avoid sports of intense contact like fightings and American football and sometimes soccer. But here in Brazil, we are doing a campaign to avoid the children to lose their head in soccer before the age of 10 years old. And this is a good option to indicate the family too. This is my team. This is our scientific meeting all this week. Everyone is invited to visit us in Brazil. This is a map of the patients. We receive patients of all countries. We are a network of 9 hospitals in Brazil. So all the patients on neurosurgery problems come to Brasilia, my city, and the capital of my country. So I invite everyone here to visit us and discuss more about this very interesting pathology. Thank you so much for this opportunity, and I'm open to answer the questions if you have. Thank you very much.
Ricardo, thank you so much. This was a brilliant presentation, and thank you for the yellow tweet, the yellow IP tweet that you showed us in the end of your lecture. So it was really a great presentation. You know, and thank you for showing us that children are not small adults, and that some of these pathologies are really complex and they need to be treated in dedicated, specialized children's neurosurgical departments. I have very quickly here a question from Dr. Junction. He asks you, how can you address a tight arachnoid band around if you don't open the dura in some of your pediatric osteoligamentar decompression only patients? Is there any trick, anything you can see on MRI, whatever?
This is a very good question. I'm trying to use more and more the ultrasound to see the CSF flow. It's a good option, I think. But of course, you need to have experience in using ultrasound and the Doppler function to understand. This is one thesis of the PhD here in Brazil. A friend of mine published good results in using ultrasound. It's a good option. The second is not only bone decompression. You have to open the layer dural space, take out the fibrils that you see in the magnophoramen, and scarring every layer of the dura. So in this kind of situations, it's very efficient, I think. When I was in Bremen, in the children hospital in Bremen, they are doing that study that I showed, the Parker Reeve study, and they only operate with open the dura patients with very large syringomyelia. And the results is good, it's good. When you're talking about the difference about duroplasty and the only bone decompression, you're not talking about the results as poor, but the duroplasty is better. But the problems is the complications. I think you have, my advice is you have to know exactly your numbers. If you have good numbers, open the dura in all the patients, please go ahead. This is a good way to treat it, the better way. But you have different situations, it's like Brazil. Brazil is a very large country. You have different situations in parts of the country. So you have a small hospital in a difficult situation of to follow the patient. You can do only the bone decompression. The patient you go to house the next day. It's very interesting. So it's only my advice. It's not because if you go to the literature, the duroplasty of course has better results.
Right, because I think this is a good message. You have to balance your own experience with best medical literature and also pay attention to the setting where you are operating, low income, middle income countries, or it really depends on the facilities you have. You have to do the best for your patient. So for the sake of time, I think we are going to move. I'm going to present very quickly on os orthodium. Try to be very quickly on this. So my lecture is on os orthodium diagnosis and treatment. Actually, what I'm talking today, it's also has also a lot of input from Professor Bruno Lee. We presented our data in WFNS Spine Committee Consensus Conference, first in August in Brazil, in São Paulo, and later on in December in Porto, here in Portugal. OO it's really rare disease with small case volume per institution. Most papers that are published offer a very small number of cases, and you don't find many comparative studies, and most of them are short follow-up, especially in asymptomatic cohorts. So the natural history is not really clear. The propensity to develop a neurological deficit or progressive instability, especially in patients not treated or asymptomatic, is not really known. There is also uncertainty on etiology, but whatever etiology it is, it doesn't really matter in terms of treatment, because this can be, from a biomechanical point of view, a highly unstable condition with abnormal translation and rotation. So we lack clear guidelines for treatment. As for clinical manifestations, OO may resemble a lot of other cervical spine diseases, cervical myelopathy, rheumatoid arthritis. You can have four main categories: incidental finding in asymptomatic patients. Most of them will come as with a neck pain, local symptoms. A substantial number of patients, sometimes 60%, depending on the literature, will have cervical myelopathy symptoms and signs, and some rare cases with symptoms related to the vertebrovascular ischemia. So there are no specific symptoms afflicting patients with OO. Regarding radiology, differential diagnosis, this is kind of more limited, and as Professor Monen showed us, persistent ossiculum terminale, third condyle, acute type 2 odontoid fracture can be the differential diagnosis. So in order to better clarify this, we need CTs and we need good MRI scans. Persistent ossiculum terminale is caused by non-union of the apex of the secondary ossification center. It's not at all related with C1, C2 instability. It's not a concern. You have also the so-called third condyle, a condyle on the midline, another congenital anomaly, no instability. Or you have something that it's more sensitive to differentiate, which is type 2 odontoid fracture. As you can see here, there is a clear history of trauma in most of the cases. However, you can see this patient for the first time when they become with a chronic dense fracture. And there are some features that allow you to distinguish from OO. The dense is on normal size and the configuration, and there is this non-union at the base of the dense. And sometimes this can be hypermobile and really behave like an ossodontodeum. Actually, the type 2 fracture that you induce in the lab, it's the paradigm for biomechanical instability of ossodontodeum. So you see all the time this smooth, well-cuticated ossicle at the superior component, and frequently you have a hypoplastic dens, which is half of the normal size. You have a wide gap between the os and the C2, and most of the time you have a hypertrophied and rounded anterior arch of the atlas. And this is really diagnostic of radiological criteria of OO. There are two anatomical types: the dystopic type, where the ossicle is fused to the basin, and this is never a concern because it's not unstable, and the orthotropic, which the OO lies in normal position on the orthotropic process. It can be fixed to the arch of C1, and the two of them, they move as a single unit. And this is a potential unstable situation. You have to do an MRI to look where the transverse ligament is. If the transverse ligament is below it's in the gap between the OO and the odontoid tip, you have a potential for instability. So it's important to properly assess those patients, because if they supervene a cervical trauma, it can be more unstable and be a cause of acute spinal cord injury. And you should suspect of instability when you have this lower position of the transverse ligament regarding to the odontoid tip defect, when there is a forward movement on C1 on C2, more than 2 millimeters on flexion view, And that you have to suspect a suspicion rate of instability whenever the OO is posterior to its normal location. We did a literature search for the WFNS consensus, and there is an interest on publications on OO after 2011. Then this was not reflected in previous guidelines that were published in 2011 precisely. And a lot of papers are small number of patients. If you filter by systematic review, clinical trial, I end up selecting 13 patients that were published after 2011, presenting with 738 patients, including some pediatric cases. And this is the papers that I selected with the numbers of patients by decreasing order, the age of patients. You see some pediatric cases. This is the only paper that compares cohorts of patients submitted to conservative versus surgery. 102 patients, 11 centers, minimum follow-up of 2 years, surgery in 71 patients. And it's interesting to see that 3 over 31 patients managed conservatively developed transient neurological deficit after minor trauma, despite having stable atlantic axial joint and enough space on the core. Zhang also showed 3 asymptomatic OO patients had significant neurological deterioration when left untreated due to minor accidents. This very important paper by Klimo, Incidental OO Current Management Strategies, advises surgery in asymptomatic patients if they are young, because we don't really have long-term follow-up data to determine the lifetime risk of leaving an OO patient untreated. If you don't have very troubled surgical anatomy, for example, normal course of the vertebral artery, if you have associated basilar invagination, if you have abnormal motion, instability, C1, C2 facet joint malalignment, if you have a narrow canal, less than 13 millimeters, you have a great risk of spinal cord injury in those patients, or spinal cord compression or limited space on MRI also correlates with the degree of myelopathy. And more obviously, if you have already an altered change in cord signal or even cord atrophy. And of course, patients that are very difficult to evaluate clinically and to comply with the counseling for conservative treatment. And I'm thinking about syndromic patients. So we tend to bolster more surgery because C1, C2 fusion has evolved greatly and now can be done by a lot of different spine surgeons with safety and success. If you choose to not operate an asymptomatic patient, you have to monitor the patient annually with radiographs and clinical evaluation to detect instability or progressing of symptoms. Probably repeat an MRI every 5 years and avoid all contact sport. From our survey, from our study on looking at the literature, is C1, C2 fusion recommended for all patients, obviously for symptomatic and stable patients based on flexion extension X-ray or spinal cord compression. They should have a C1, C2 fusion procedure. Consider the safety of C1, C2 techniques. Incident discovered OO surgery can be offered on an individual base, based on the criteria that I told you and on the expertise of the counseling surgeon. Now here we look at the type of surgery that was done in these papers that I selected. They have good clinical outcome looking on MJOA, on VAS and NDI, with fusion rates that are close to 100%, with small number of complications and no case of mortality was reported. Doing a C1, C2 fixation in OO patient is really the same, achieves the same results, and no difference in fusion rate with no OO patient that you do a C1, C2 fixation. What about posterior sublaminar wiring? 13% of patients in this paper develop a non-union or wire breakage. Klimo before in 2008 showed that 15% had successful surgery. Illinois also in 2019, the rate of non-union is higher in children which received non-rigid instrumentation. And Bizoki also, one of our panelists, also showed that this could be a problem. Goel published a paper with 190 cases of OO. There was an improvement in JOA and DAS, 100% fusion rate, no major morbidity. Even cases of fixed or irreducible instability, AAD with basilar invagination that could be very nicely treated with this C1, C2 fixation. And no cases of transoral or posterior foramen magnum decompression were done. And neither also occipital fixation were done. So what are the recommended or avoidable fusion techniques for OO? The posterior C1, C2 fixation is the recommended type of surgery, effective, improvement of symptoms, and good fusion rate. Cable, wires, hooks should be avoided because that wire failure and lower fusion rates. There are no really descriptions in the literature of anterior C1, C2 transfat fixation in this kind of patients. And certainly odontoid screw fixation has no role in the treatment of this factor. If we look at that C0 cervical fixation, some of the papers that I selected showed this possibility, only 4 out of 13 papers. They are not really reported. They are associated when they are done with more complications, almost 30% of complications. And they do it in this topic, OO, if OC movement is possible. So what is the criteria to include occiput in fusion technique in OO? Routine extension or fixation to occiput is not recommended unless you have atlanto-occipital dissociation, C1 abnormalities, not permitting implantation of the screw. If you have repeated failed attempt of atlantoaxial fusion, or you have done an anterior odontodectomy and you are facing instability. What about cases of OO that are irreducible? There are some papers that identify irreducible patients among their reported cohort, and a lot of them were just solved with C1, C2 fixation, and one paper did transoral approach in nine of the cases, but certainly not much reports on that. This paper by Shao with 41 patients, they did a heavyweight skull traction, assisted loosening of the lateral atlantoaxial joint, what they call the axial loosening, and they have a successful reduction without the need for anterior decompression. And even Illinois on 5 patients with irreducible OO did only transoral in 1 case. In this paper that I cited before from Goel, 74 cases of irreducible, and with joint manipulation and distraction was possible to solve the problem. So regardless of the reducibility, the primary focus should be on the joint and not on the decompression. Transoral, it's not routinely recommended to treat it reducible AAD caused by OO due to the morbidity. The focus should be on correction of the deformity, and once you correct the deformity, it's very likely that the neural compression will be as well solved. Let me just show very briefly a case that illustrates something that you should not do, at the worldwide level when you are receiving an OO patient. In December 2012, I saw this 48 years old male patient with neck pain, progressive tetraparesis, grade 4- with Cronus, Babinski, and jaw of 12. He had a previous operation in another institution 3 years before. And this is his MRI after this previous operation, and you see still compression on the craniovertebral junction of the spinal cord. And look at the instability in flexion extension, AAD 12.4, PADI 14.4 to 8.8 from extension to flexion. And look at the change also in the relative position of the hooks, which means that there is multi-directional instability in this case. It's not only translation. sessional plane translation. Here you can see the translation, very narrow space for the spinal cord, a Roland index of 9.8 degrees, as you see drawn here in the extension flexion X-rays, and if it is more than 20, there is a high risk of myelopathy. Lateral bending show also important compression, flexion extension MRI, important compression. And I guess if you look at the surgical anatomy of C2 pedicles in this patient, you see a very thin pedicle here. And I believe this was the reason why the surgeons did this kind of hook procedure instead of attempting to do a C1 fixation. Of course, you have to be aware of the eye and middle right of the vertebral artery, which is the vertebral artery really going up and medially, which erodes and thins the pedicle and the lateral mass and makes it virtually impossible for you to insert a pedicle screw in situ. And these are the kind of variations between the loop of C2 from what you think is normal and the relation with the loops and the pedicles and how thin the pedicles can be. So what we did in this patient, we did an hybrid construct, which is a transpedicle screw and C2 on one side and the translaminar screw on the other side. This is just an operative field. We do it under a microscope with a good control of hemostasis to be able to see everything. We could achieve a partial reduction, important reduction in traction. We did a C1 laminectomy, and we can argue about the need of C1 laminectomy, and we did C1, C2 transped on the left side and translaminar on the right side. This is the radiological outcome, good space for the spinal cord, as you see here. Also important to extend the decompression if you're going to do it laterally out to the condyle, so you'll be able to see CSF flowing laterally. And this is what we achieve on the post-op space for the spinal cord, and no more instability on flexion extension X-rays. There was a slight kyphotic effect of the construct, which was compensated by subaxial lordosis, and this was not really a problem for the patient. This is a good radiological outcome, enlargement of the canal despite an atrophic spinal cord. So in terms of conclusions, I think all symptomatic or unstable patients who have a C1, C2 fusion procedure, incidentally discovered OO should be offered surgery on an individual basis, taking into account the predictive factors from neurological deterioration and the expertise of the surgeon. If you think you are not able to do the procedure, you should refer the patient. C1, C2 fixation is the recommended type of surgery. Fixation with cable, wires, hooks. It's very unexceptional, maybe in some cases of children, and should be avoided. It's associated with hardware failure and low rates of fusion. Routine extension of fixation to the occiput is not recommended, and anterior thoracic decompression is not really recommended to treat irreducible AAD patients with OO. Thank you.
Thank you very much, Professor Oscar Alves. It's a great talk as usual. Thank you very much. I think we proceed and we make discussion at the end of the session. Can you introduce our next speaker, Oscar?
Right. So now we're going to move to the session on basilar invagination, and Onur Yaman, eminent spine surgeon from Istanbul, Turkey, will talk us about diagnostic criteria, radiology, and classification. And I think this is very important to talk, to frame the discussion that and the lectures that will come next. Onur, please. Well, I think there is a problem here with Onur.
I'm just looking for him.
Yes.
My attendees, just give me 1 minute. If
Yes.
he's not able to join, he can speak later and we proceed to our next speaker. Just 1 second, Oscar.
Nasser, I don't think you've seen.
Okay, okay. And so in
Don't
such
worry,
case,
we're gonna move to the next
Okay,
presentation. And Ricardo, I believe also will talk us about radiology and classification. Ricardo Botelho is a good friend of mine, almost like a brother in Brazil. Is a prolific researcher on basilar invagination. He actually is one of the 2 or 3 guys in the world that publish more on basilar invagination. And he knows more about the disease than anybody else. And he has very clear ideas, very simple ideas that can be applied all over the world. So it will be my great pleasure, Ricardo, to listen to you and give you the stage for this worldwide audience. Thank you, Ricardo.
Thank you for your nice words. I'd like to congratulate to our colleagues from Egypt. Let me only share my screen. Okay, then thank you, Oscar, for this nice invitation. Dr. Nasser, it's a pleasure to stay here. Oh, our friends from every part of the world, from World Federation of Neurosurgical Societies. This is my city, São Paulo. This is one of our 2 hospitals, this Hospital Servidor Público from the state of São Paulo, where I live. And my email is here, if you want to talk to me. Dear colleagues, good to be here with you again. Let's leave this. Okay. This is the X-ray of a typical basilar invagination. What we show here is the invagination of the upper cervical spine. It was always considered as an invagination of the odontoid process. As we can see here, is that the atlas is very important of this disease. I will try to show that who invaginates is the atlas and not only the odontoid process. Can you hear me?
yes, yes, it's very good.
Ricardo, just next slide.
Okay, I pass to the next. My screen is stopped. Let's see what happened. I will stop share in a moment and
Yes.
share again to see what happened.
Yeah, just screen more.
Okay.
Ricardo,
Okay, let's.
yes.
Okay.
Yes,
Okay.
yes, very good.
We have in the world several types of manifestations. We could analyze several countries and to look at the association of new factors and try to classify the several kinds of malformations. We did an effort, I, myself, and Oscar Alves, and Dr. Klicken from Germany. We look at the literature, looking for samples that could show what is the sample in each country of the world. We were able to divide into unstable and stable diseases. And all literature can be divided in unstable or stable. The unstable is composed for any kind of Chiari malformation, mainly in adults, or type 2 basilar invagination. And unstable are composed by basilar invagination and atlantoaxial dislocation. This is needed because there is a lot of confusion using the terms atlantoaxial dislocation, even for basilar invagination and for other types of malformations. I don't know why my screen is stopped again. Okay. Then these are the kinds of malformation that we can see in every publication in the world, unstable and stable. Recently, we look at the Chamberlain's violation to define how we should do the real diagnosis of basilar invagination. The literature, there is a different values for the diagnosis of basilar invagination. Frequently using Chamberlain as the reference. But when we look to the Chamberlain's line, there is not a reference, only the atlas above the basal line. And Chamberlain thought that basal line is above the atlas in normal citizens. When we look at the normal subjects, all of them have the atlas below the Chamberlain line. Then any violation of Chamberlain line is diagnostic of basilar invagination. And any odontoid violation above McRae's line is diagnosis of type 1 basilar invagination. We look at the cranial and craniovertebral junction changes in basilar invagination, comparing type 1 and type 2. When you look at type 1 were those associated with assimilation of anterior arc of atlas. This is the most common, most frequent, most constant malformation associated with type 1. Then assimilation of the anterior arc of atlas is part of the diagnosis of type 1 basilar invagination. But now we must take a look, a more amplified look at this disease. We can look only for C1 and C2. We must take a look at the whole skull in relation with the cervical spine. We studied the cranial base flexion in this disease and could see that cranial base flexion is related to the platybasia in this disease, what is very common. When we look at craniocervical kyphosis, basilar invagination are very different from Chiari malformation. Chiari malformation have a craniometry very similar to the normal patients. And basilar invagination have a flexed skull. Okay. Again, here is the head and neck flexion angle. There is a very acute angle in basilar invagination and frequently associated with platybasia. And what we look at the center, at the bottom of this picture, is is the roundness of the skull of the basilar invagination. They are frequently associated with brachycephaly. Then, several skull structures conjoin to the pathophysiology of this disease, is not only C1 and C2 alterations. Take a look at the amount of craniocervical angulations. The angle between skull and spine is less than a half of 90 degrees. This makes part of the pathophysiology of this disease. And it seems very different in type 2 and type 1 basilar invagination. Those cases associated with assimilation of the anterior and posterior arc of atlas. But although in the group 2, they had a more acute head inflection angle, there is a specific sample inside the type 1 basilar invagination in which the clivus has almost 90-degree angle with the cervical spine. It's frequently very flexed, what erase some doubts about the ability of only C1, C2 small lever to treat this pathology. In a third of type 1 basilar invagilation, this is what happens, a very flexed skull related to cervical spine. And here is one of the most frequent talks about basilar invagination, the craniocervical angle or clivus canal angle. They were very different in type 1 and type 2 basilar invagination, suggesting that these two pathologies are different or very different. There is some correlation between the basal angle, as you can see in this picture. If the basal angle is very large, the craniocervical kyphosis is increased. The angle is acute between skull and spine. What doesn't happen in a almost normal angle? You can see this difference in these slides. There is a relationship between basilar invagination, recently described, and brachycephaly. It was described, as long as I know, for a group from the northeast of Brazil. They studied the cephalic index, a division of the maximum width with the maximum length of the skull. And as you can see in this slide, as the patient becomes brachycephalic, as more invaginated are the odontoid process. Then there's a relation between the brachycephaly and basilar invagination. This is one of our works. We compared with the normal population at the right and brachycephalic at the left. You can see the brachycephalic has a rounded skull that you can see in the axial scans, CT or MRI. Take a look at the axial scan of one basilar invagination patient. You can see here in this slide that the head is round. All this skull has some relationship one to each others. When we look at the brachycephaly, 80% of type 1 basilar invagination are brachycephalic, and almost 43% are hyperbrachycephalic. The skull is very different. And the last is the atlas assimilation. That is very important in these two pathologies. When we look at the difference of atlas assimilation of type 1 and 2 basilar invagination, we can see that anterior arc atlas assimilation leads to type 1 basilar invagination. This makes part of the pathophysiology. And in type 2 basilar invagination, the posterior are frequently simulated. What brings the atlas very close to the skull, bringing the odontoid together. That's the cause of the upper position of the odontoid process. And when we look at the types of relation between the odontoid and atlas in type 1 basilar invagination, they can be divided in 3 types. One in which the odontoid is separated from the atlas. One is the odontoid is close to the atlas, joined to the atlas. In this case, frequently you can even still operate without fixation. We have several cases. And the last, there is some kind of stop of the migration from the odontoid process from some bone formation above. 1/3 of our patients has this kind of fashion. When we look what happens with the skull in the embryology, in embryology, the atlas is assimilated to the skull. After separation, look, the basal is along with atlas, and odontoid is posterior. When the separation occurs in embryology, the skull goes to the back part, atlas goes to the front of the basal, and odontoid is in line with the basal. If the odontoid is back to the basal, this is an indicative of type 1 basilar invagination. As you can see here, atlas in line with the clivus is an indicative of type 1 basilar invagination. But there is also strong evidence of posterior fossa under development from all the countries that published. There is, in meta-analysis, a difference in clivus length, in sagittal dimensions, and the supraoccipital and posterior fossa volume, such that this case cannot be considered formation by a really malformation of the bone. And we look at the instability. The skull may be realigned in this case, but the distraction must be carefully evaluated because the normal position of the C2 is at the back of C1. This is the position. Then take care to distract C1 and C2 and try to realign this relationship. This is an example. Type 1 basilar invagination realigned under extension of the skull in relation to the cervical spine. In this case, if a big migration, what happened with this case? You should have care to study the relationship of the atlas with the axis in both sides. Frequently, you have some malformation, and the inclination of this situation produces this kind of invagination. And you can solve distraction only one side. Okay, this instability, you can realign the skull, and you can solve even the tentorial inclination, the clivus inclination, realigning the skull. That's why we continue insisting in realignment of the skull in relation to the basilar invagination in those cases that need to be compensated. In this slide at the left, a fixation of the skull only to the upper cervical spine permits to the hyperlordotic may be compensated with a normal realignment by the muscle. Then our trend is to only fixate the upper cervical spine and not to insert the screws below C2 if you can. Here's the realignment and posterior fossa decompression, and the almost normal sagittal balance acquired in these patients. Then, how to treat stable cases? Stable cases, we have done a surgical described by Juan Sarruquillo from Spain. I don't know if these were described before. He called as posterior fossa reconstruction is an extra arachnoidal dissection to maintain the cisterna magna intact to avoid ptosis, cerebellar ptosis. And as several colleagues described, we can maintain great part of cisterna magna intact and leaving the cisterna. This is one case of basilar invagination, ventral compression that can be decompressed. You can see CSF in front, CSF in foramen magnum. Other cases, if ventral compression, a tightness foramen magnum, and what happened even with the angulation after posterior fossa decompression only. Several cases, one case more, clavis canal angle acute, ventral brainstem compression that can be alleviated, but I do not rely on small decompression. I believe that there is other parts above the foramen magnum that are compressing, and we must create space to alleviate the posterior fossa. And another case, and several cases. Then, in our experience, the posterior fossa can alleviate the basilar invagination, type 2, in the great majority. And a discussion if we should do a realignment, a craniocervical realignment in type 2 basilar invagination. This is one case. I think that scalp traction can realign several cases, but this patient didn't go well. She couldn't swallow, and she died after a complication with a feeding tube. Then, is this need to realign in type 2? I consider that we can decompress almost all cases with a posterior fossa decompression without realigning a type 2 basilar invagination, but we are waiting for the data from other papers to know if we need, in fact, to realign. Then we still consider the conditions in that instability are reduced and fixed. Type 2 basilar invagination are decompressed frequently by the posterior approach, and only other techniques are used only to cases that we couldn't achieve the decompression. In conclusion, the base occipital underdevelopment, now we study just now the sphenoid bone in this case, and now we know that even the sphenoid bone is different in basilar invagination. Then the wall cranial are underdeveloped in basilar invagination. The base cranial is different. Foramen magnum decompression, we prefer even the term posterior fossa decompress. Type 1 realign infused, type 2 posterior fossa decompression. And other techniques we can't be able to treat this patient. That's it, Oscar. Thank you for your attention.
Ricardo, thank you. This is a lifetime presentation. I think you are unique in the way that you study your patients and you present your patients. And certainly your experience is very valid. I know your work, and it's in big contrast with other options that we have been hearing in recent times. And I think it's with low technology, with a good understanding of the pathophysiology, you can do a lot for those patients with very simple operations. And this is a very important message for low middle income countries. You don't need to have screws and very complicated things to do and to solve these patients. And you show the reason why this is possible. So I call Mehmet Zileli from Turkey, is also a very known worldwide educator in spine surgery. He's from Izmir. Mehmet, it's always a pleasure to listen to you.
Hi.
And after Ricardo told us that he can do everything only by decompression, you have had time to convince us that we need to put C1, C2 screw. Thank you. Please start your lecture.
Thanks a lot. Do you see my?
Not yet. Not yet.
Not yet.
Okay, it's now.
What about now?
Yes. Just please put on screen mode. Screen mode.
Okay.
Bottom right. Perfect. It's good.
Is it okay?
Perfect.
I thank you and all the organizers for inviting me to this very nice panel seminar. I will talk about the posterior C1, C2 fixation, including occiput to treat basilar invagination. We did a literature search and we could find 30 papers from the last 10 years, including basilar invagination and occipitocervical fixation and basilar invagination and C1, C2 fixation. In fact, the reducibility and reduction techniques have been already mentioned many years before. And the concept of reducibility is first described by Menezes. And we know that the preoperative images may not be enough for decision. For the irreducible pathologies, the etiology is multiple. And Atul Goel claims that all cases of basilar invagination can be reduced. And fusion of C1 arch and odontoid process, bony anomaly, contracted anterior soft tissues, previous surgery and filler, and position of the vertebral artery and occlusion in case of reduction are some irreducibility reasons. If not reduced at all, an odontoid resection may be applied. What are the reduction techniques? Actually, there are one preoperative cranial traction, intraoperative traction, posterior intra-articular release, cantilever reduction and posterior occipitocervical fixation, posterior osteotomy, transferal odontoidectomy, and posterior occipitocervical fusion, which is not actually reduction. Instead, it is a without reduction decompression, anterior release and posterior reduction techniques, and transoral atlantoaxial reduction plate, which Dr. Uzi will talk about this later. Preoperative cranial traction has been tried mostly in pediatric patients. This is one of the papers from 2021. Hollow vest is applied, and after 46 weeks, a CT scan is obtained by reduction in that period, in the weeks. And if a favorable reduction is achieved, then the posterior arthrodesis is done. This is some steps of reduction with application of more traction. Intraoperative traction under general anesthesia, it is routinely done by some authors, in addition to the distraction and spacer cage insertion. What about posterior intra-articular release? This is the so-called Dr. Goel's technique. It is well known and commonly used, and I also use as many others. And it is it results with reducible cases in many instances. This one is cantilever reduction and posterior occipitocervical fixation. And according to the posterior occipitocervical angle, this is the angle, you can provide a pre-banded rod and then apply to your reduction according to that band rod. This, without exposure of C1, C2 joint, posterior reduction can also be achieved. This is a Chinese group from 2015. They were doing two steps reduction. First was a distraction between the occipitocervical junction of the rod and the occipital screws to take the odontoid process out of the cranium. And then in second step, to translate the odontoid process ventrally. Another reduction without C1, C2 joint manipulation is by using an intraoperatively manipulation of occiput and C2 distraction and head backwards extension to achieve restoration. This is another technique similar to the previous ones, and we again without interfering C1, C2 joints. A distraction between occipital part of the rod and fixated occipital plate reduced the atlantodental interval. This is a posterior drilling and wedge osteotomy of the joint, or a so-called posterior osteotomy in pediatric patients to provide reducibility. Another posterior osteotomy technique by using real osteotomes. Actually, this may be scary for many neurosurgeons. However, it was used to release the bony fusion of facet joints, and a specially designed rotating cutter was used to distract and prepare the facet joint space. Actually, this is not really a reduction technique, but this is achieving anterior and posterior decompression and posterior fixation without a reduction. This is a historical technique. It is not much used in today's surgical armamentarium. This technique from Wang and co-workers from 2017, transferal atlantoaxial release and posterior reduction without an odontoidectomy can also provide a good reduction. This anterior release and posterior reduction by a group of Indian authors, they have done that technique with occipitocervical fixation in 18 and C1, C2 transarticular screw fixation in one patient. It can be also done not a transferal approach, but a retropharyngeal approach. Anterior release and posterior reduction can also be done by placing a titanium cage into the joint from ventral, and then turning the patient back and occipitocervical fusion using a plate and screw construct. Actually, I will not talk much about this technique because our Chinese friends will have described this, and then it is a transferal atlantoaxial reduction plate or TARP fixation. This was only one approach, no combined approach, and everything could be done by a ventral only surgery. This is again a technique used for with this TARP fixation. And these authors have compared TARP technique with occipitocervical fixation, and they say that the performance of reduction and decompression and earlier bone fusion rates of TARP technique are superior than occipitocervical fixation. And some other authors have added a transferal intra-articular case distraction and C-jaws fixation for revision of basilar invagination without a posterior approach. So our previous algorithm was like this, but today we must use this type of an algorithm looking at the reducibility. If it is reducible, C1, C2 fixation and or occiput C1, C2 fixation is okay. But if it is reducible, there are multiple techniques like you can see here. In case it is not reduced, you can make a C1, C2 osteotomy, or you can prefer odontoresection and occiput C2 fixation. These are our recommendations as the spine committee of WFNS. We tell that most cases of basilar invagination and atlantoaxial instability can be treated by Goyal's technique of C1, C2 fixation, distraction of the atlantoaxial joint by a spacer or bone graft. Irreducibility criteria are not very clear. Preoperative or intraoperative cranial traction, drilling of facets and osteotomy, cantilever reduction and posterior occipital fixation without C1, C2 joint manipulation, anterior release followed by posterior fixation, and transferal atlantoaxial reduction plate are some options to reduce the basilar invagination. Current evidence is lacking which technique is better than the others. And there is no high quality study, even no level 3 study comparing C1, C2 fixation with occiput C2 fixation in basilar invagination patients. An occiput cervical fixation can be used in case of atlas accumulation, dyskinesis of C1 lateral mass, in irreducible cases, and if a transferal odontal resection was done, and occiput cervical fixation may be preferred for revision of failed C1, C2 fixations. Thank you for listening to me.
Thank you, Mehmet. Excellent presentation, as always. Very good overview of different techniques. I'm sure we can have a later discussion because Ricardo puts a lot of emphasis on decompression, whereas you and also the Chinese friends will tell us a lot about joint manipulation and deformity correction. So it's my pleasure to introduce the next speaker, which is also a good friend from China. Hi, Fusi. It's a pleasure to have you here with us once again. And he's going to develop the topic of anterior surgery for basilar invagination. Please, you have like 15 minutes, so we can accommodate also the next speaker before we close at 4:30 or 3:50 in the afternoon. Okay, Pussy, please.
Okay, thank you, Dr. Oscar. I will share my screen.
Right.
Okay.
It's perfect. Perfect.
Can you see the screen?
Well, yes, perfect.
Okay. My topic today is transhour surgery for basilar invagination. As the former speaker has said a lot about the posterior approach and many techniques about the basilar imagination. My topic is about the transoral approach, how to control the basilar imagination by the transoral technique. As we know that the basilar imagination goals classification is divided in two types, type 1, type 2. Type 1 is combined with the C12 dislocation, and type 2 is no dislocation. And type 1 is most common type in CVD deformation, and always be with combined with C12 dislocation, cherry deformation, and C1 assimilation and Klippel syndrome. I cannot see the title. Traditional treatment of basilar imagination always include a decompression of posterior cranial fossa. Here's a case from the posterior approach. You can see that the posterior fossa have been decompressed, and the dislocation is still exists. And although the hole is very big, the dislocation is still there, and the syringomyelia and the tonsillar herniation is still there. Another method always is that in sufficient reduction of Atlantic axial joint with occipital cervical or C12 fixation. However, we can see that the compression of spinal cord is very serious and without any result, without any effect. And we all know that a common failure includes the full reduction of an Atlantic axial joint is the most important, and that means that full reduction equals to thorough decompression of the spinal cord. And the common choice include one-stage transoral release followed by posterior fixation. And his advantage is that it can get satisfactory reduction and a good surgical outcome. But during surgery, because it has two approaches, so the cervical spine will become extremely unstable after transoral release, so that the potential cord injury may occur when turning over. So that is although he has a good result, but it has two approaches. And another choice is posterior joint release followed by posterior internal fixation. As we know that from posterior can insert a mesh cage and all the bone graft, and then distract the C12. So the basilar imagination can be reduction and can get a full reduction and have satisfactory reduction and good surgical outcome. But the disadvantage is that it is not suitable for all the cases, especially with the severe dislocation for the case with severely inclining and locking facet of C12. Such as this case, the C1 lateral mass has dropped onto the anterior surface of C2 body. So it's difficult from the posterior approach. You can see that it is more vertical, so it's difficult for posterior approach. So we designed transoral Atlanta axial reduction plate. You can see from the animation, you can see that we get the during the operation we can get the full reduction. after the anterior transoral release and use reductor and the top, we can get the instant reduction. So that is a good choice for us to get the thorough reduction of BI. Here is the plate at the top. Our study experienced that we started our research in 1999, and the first operation was confirmed in 2003, and the first paper is in Spine in 2005. And nowadays, we have performed more than 1,000 cases of TAP operation, and about 100 upper cervical operations were performed every year in my department. A lot of surgeons have asked us why you are so many cases. So I answered that because in China there are a lot of people, so we have a large number of cases. There are two units, two centers in China. One is in Peking and another is in Guangzhou. So we have a lot of patients about upper cervical spine, and of course, including the basilar invagination. Here is the top one, is 2003. You can see that the C2 screw is unicortical. So it is not very strong. Sometimes redislocation will happen. So we changed to 2005 to bicortical screw of C2. It becomes strong, but it is dangerous to the spinal cord because it penetrates the posterior cortex of the vertebral body of C2. So we changed our idea to top 3. Use the transoral reverse pedicle screw of C2. So it becomes very strong. You can see that it's just like the posterior pedicle screw, but we changed from the transoral approach. So the plate internal fixation is very strong. After we use this technique, dislocation of C12 seldom happen. And we changed to top 4 to 6 hole, because use this shape, you can after have a reduction, we put two small screw into the C2 vertebrae. Then we can take out the reductor so that we can have enough space for insert the 2 important C2 reverse pedicle screw. And this is during the operation. You can see that the long pedicle screw by transoral approach. Here is our top plate. Obviously, the core of an ideal reduction is the release technique. If you cannot have a Atlantic show thorough release, any internal fixator cannot get thorough reduction of Atlantic axial joint. So the very important thing is that we must have a thorough release. So because we are familiar with the transoral approach technique, so we have performed a lot of patients in our experience. I designed this technique in a 4-grade transoral release technique. This paper will be published in this the following month, perhaps. I call this 4-grade release technique. Grade 1 is originated from the anterior soft tissue, including the anterior capsule and the bone callus and so on. If we cannot get thorough release, we'll change to grade 2. I called this technique 360-degree soft tissue release, and the grade 3 include the odontodectomy, and the grade 4 is the osteotomy of C12, because C12 has the bone fusion. So we must cut down this fusion. Then we can change the reducible dislocation to reducible. how to judge if we have a thorough release. From this paper, you can see that we'll use a 2 millimeter Kerrison roller and insert the interspace of the C12 and pry and lift the C2 body during the skull traction in extension position. If we find that C2, the body and the dens had
I think we had a little problem here.
Okay.
Hi, are you back? We had a little interruption here. Please continue. You can go. You can proceed. It's okay. We are seeing you and your presentation. Just proceed, please. We are not listening to you. I think this is probably bad internet connection. Can you please unshare your screen and start again? And I don't know if Mehmet Zileli is around. Mehmet, are you available? Mehmet?
Yes, I am here.
While we can solve the problem, can you answer very quickly to Dr. Nasser Al-Sharif? He's asking very simple question. How can you know that the basilar invagination is reducible? Very telegraphic answer.
Yeah, I have already answered that in my slides. Actually, we are not sure. There is no good test to answer this. Although flexion extension films or flexion extension MR images may be helpful, but we cannot rely only the films.
But you do some traction maneuvers with the patient anesthetized, also in the OR. You can assess. That's the next step, right?
Yes, yes.
Okay.
Most of the times we learn it during surgery.
Yes, absolutely. So can we go back to Dr. Fusi?
Okay. Can you hear me now?
Yes.
Okay, thank you. So that the important release technique for BI will be the grade 2 release technique. I call this 360-degree release of the C12 joint. I will tell in detail. Step 1, completely remove the anterior arch and the bite of the apical and the alar ligament by Kerrison roller. Then we'll come to step 2. We'll bite down the lateral posterior scar along the posterior edges of the dens. After reaching the inflection point, bite of the posterior joint capsule to complete the 360 release of the Atlantic axial joint. Here we show you how we perform the grade 2 release. Cut down the 3 ligament and along the posterior edge to the poster capsule of the facet joint. After that, we can get a thorough cut down all the connection of C12, so we will get the fully release of the joint. I will show you some typical case. The first case is a 32-year-old male. You can see that he had a basilar invagination and with the torticollis. And the pre-op dynamic view, we can see that even after the extension, we cannot get a thorough reduction. And from the CT scan, we can see that the C1
I think we had a problem. Ricardo, are you there? Ricardo, we have here a very provocative question from Dr. Kubilay Murat, telling that some of the cases that you show are more platybasia cases and not in basilar invagination cases. And this is probably the reason why decompression works, and is a believer more on Goel technique for basilar invagination. Can you give a brief comment, just 2 minutes, because we need to bring Massimiliano Visocchi also on the stage.
Yeah, we are waiting for the results. In platybasic patients, they must make a flexion of the skull in relation to the cervical spine. We don't know if C1, C2 have a large leverage arm to correct this kind of. We are waiting for the results. Let's the time shows. We don't have these results until now. In platybasic patients, I don't believe C1, C2 will be the solution.
Okay, Ricardo. Dr. Fusi, I think we have problems with your internet connection here, and we have only 15 minutes left before closing. I think we understand very nicely your technique, which is really great technique, very elegant. And I would like to call Massimiliano Visocchi now. If Massimiliano is around, Massimiliano, you have exactly 15 minutes. We need to close in 15 minutes. Dr. Fusi, once again, I'm sorry, but we can understand very well your technique, very elegant, and the results that you are showing us. But I'm sorry, we need to move to Dr. Massimiliano. Okay, I'm sorry.
Thank you so much. I'm sorry for having many problems. Do you hear me, first of all?
Yes, Massimiliano, can you share your screen, please?
Yes, I want to share my screen, but the speaker before me should close.
It's done. It is done already.
Yeah.
Share your screen, please, Massimiliano.
No, I have not the key for screen for sharing my screen because I need to see the written banner with the shared screen. But
can Nasser help on this?
It is allowed. You are allowed to share the screen. Just you can go down to the green button.
I think that this screen is of the speakers before me, belongs to the speaker before me. I don't see the.
No, there is no anyone sharing screen now.
No one is sharing, Massimiliano. You should be able to
share. I don't see any key for sharing the screen. I get out and return back in a few seconds, okay?
Okay, that's much better.
Okay, I'll come back. Yes.
Now I see the banner. Okay, very good. Do you see my slide?
Yes, but not yet.
Not yet. Now
we see it now.
You see it.
Yes, please. Put on
Okay,
screen.
very good. Thank you so much for inviting me. Thanks so much to Dr. Nasser El-Ghandour, to
Thank you.
Oscar Alves, to Mehmet Zileli, to Borgelo, to all my friends, who are united along with me and many others by the common interest in craniovertebral junction surgery. As far as you know, many speakers before me already clarified the ideal limits of craniovertebral junction, the local anatomy. You know, we know everybody all the bone and ligamentous typical pattern of craniovertebral junction, as well as its neural inside tissue, and also the embryological origin of such a complex system. We recognize in ProAtlas the key point, the key vertebral primordia involved in the formation of skull base C1, C2 tip. And also kinematic is very typical and very unique. Surgical indication spans from malformative, acquired, post-traumatic, infective, and degenerative and tumoral pathology, and also trivial assault are involved in this surgical challenge. We try to organize all the updated literature in a book and many other publications, trying to identify the 360-degree surgical access allowed by local anatomy. We defined the anterior posterior approach, anterolateral posterolateral approach, and extramucosal intramucosal approach, and we spend a lot of time in our cadaver lab in order to better investigate on the most effective approach. This is a typical posterolateral or farlateral approach on the left side. On the other side, in the right side, we see this different surgical position and key incision for extreme lateral anterolateral approach. A semi-sitting position is to be avoided in order to avoid the risk of air embolism. And all of us know the 3 and 4 layers of craniovertebral junction in posterolateral approach, as well as in anterolateral approach. We see the same anatomy, but from a different point of view, including also the epiaortic vessel absence in posterolateral. With the anterolateral, we control at the same time carotid, jugular vein, vertebral artery, and first of all, we have to look for the accessory nerve beneath the fat pillow underlying the sternocleidomastoid muscle. As well as we recognize it, we can forward to the triangle and identify all the same structures that we have in the classic posterolateral approach. But as you know, my most striking interest is for transmucosal and extramucosal anterior approach. This is a typical extramucosal anterior approach. You can see the skin signature of this classic approach, the typical rhomboid approach to gain access to the craniovertebral junction. According to Salle, we can control all the surgical field included in the sum of transnasal, transoral, and Volinsky ascending transcervical approach. This is theory, this is cadaver lab experience, but we will see that, as a matter of fact, in clinical practice, something can change. This is a very schematic drawing of a submandibular approach. Number one, to identify and shift upward the hypoglossal nerve. Number two, to medialize the pharynx and the pharyngo-urethral muscles, and as soon as I identify the superior laryngeal nerve, we shift it downwards At the same time, we identify the vertebral artery and the tripods, carotid tripods. We can cut the facial artery as well as the lingual artery to better expose the surgical theater. Submandibular gland is the first step of the classic approach. You identify, isolate it, and shift upwards, and then it appears the anterior belly of the gastric muscle, posterior belly of the gastric muscle, with the tendon under this structure. You can identify hypoglossal nerve, and you shift it upwards, and this is the lingual artery, and this is the surgical plan, surgical field exposed at cadaver lab. But you know that clinical practice is quite different. Starting from this classic approach, we try to investigate a shortened approach with only 3 steps, very similar to the Cloward approach for anterior cervical decompression infusion, very similar conceptually, without isolating hypoglossal nerve, without isolating superior laryngeal nerve, without cutting any vessel, just cutting the skin over the target. This is a very simple and focalized C2 chordoma, and this is O-arm identification of the target. You see how uneasy is the position of the surgeon, but as you identify extramucosally the craniovertebral junction correctly, you identify the tumor. This is the C2 filled by the chordoma structure, the odontoid, before and after removal. But we tried also to extend our surgical control with a more upward located tumor between C0 and C1. This chordoma is located at the yellow ligament area, and we decided to operate with the submandibular approach only because the patient was harboring a Behçet disease, and to avoid the transmucosal approach and the risk of some mucosal dysfunction. So we discussed the opportunity to interact with craniovertebral junction, the upper craniovertebral junction, with this uneasy approach. And although we were very confident to manage it at the best, we were obligated to use an endoscope and no more microscope, because a microscope was not easy and consistent with this high oblique extramucosal approach. This is the endoscopic view, and we have a very brief video suggesting us to control in an easy manner the tumor, but we decided to stop since we hadn't the oblique control of this huge tumor, and we were confirmed in post-op MRI showing only a biopsy. We were able to perform only a biopsy with this uneasy and not indicated approach. So we shifted to transnasal approach. The transnasal is another point of discussion. According to our experience with transnasal, we can control only green spots, and just indicated for severe platybasia, like the B type of 2 type of Goer classification. You can't approach this severe basilar invagination associated with the platybasia with transoral. You have to perform a transnasal. On the other hand, on the right side of the panel, you can see a reducible basilar invagination that can be approached by posterior instrumentation and fusion. The pathybasia associated with basilar invagination, it has a typical retroversed lordotic dents, because during embryological development, the dents shift backward. And we have to keep in mind this finding. Other speakers before me spoke so clearly about Chiari malformation. I just want to spend a few words about the type 1.5 Chiari malformation. They are suitable for decompression and anterior decompression, transnasal and transoral, when irreducible. Otherwise, we can reduce it by posterior instrumentation and fusion. But let's move and shift to the transnasal endoscopic approach again, optimal control of the clivus. And this is an example that I love to show because it is a monster chordoma that we approached by transnasal. At the end of the video, you see the carotid artery that you can identify in this reconstruction of neuronavigation. Here, carotid, here, carotid artery, and the surgical removal of the tumor by transnasal. With the endoscope, we can move on transoral as well as at the same time, one stage combined, and we take off the endoscope and we move to the microscope to further decompress the tumor residual. Let's move to transoral approach. Transoral is very suitable for the green point. In other words, not suitable for the clivus, at least from a theoretical point of view, but suitable for arterial arc and the odontoid. Nevertheless, we can also
sorry to interrupt you.
When we started with neuronavigation and with neuromonitoring to perform such a surgery, we started with a typical microsurgical technique. You see here the tongue, here the lateral walls of the pharynx, anterior arc of C1. This is a classic old-fashioned drill, and the CUSA, which is very important to identify the ligament, to profile the odontoid. You see the odontoid here, which is removed with the ligament, and again with the neuronavigation we can better orientate to circumline the tumor, then the reconstruction in 3 layers, and surgical post-operative control. This is another challenging case with the non-union post-traumatic lesion. This is a pre-op and post-op MRI finding of this clinical case, and it was very satisfying for our experimentation. And this is a typical drawing of cervical ascending extramucosal Wolinski approach, the same approach that we use for infibulation of C2 fracture, but it has some drawbacks. Green dots are suitable for this approach, red dots are not suitable. So you can't remove anterior arc of C1 with the Wolinski approach, but only the odontoid. No control at all of the clivus. Again, experience can seem sometimes against the doctrine. This is a very challenging case that I like to show. Is children with platybasia and basilar invagination according to Goel type 2 basilar invagination, along with bifidism of C1 and also Chiari formation according to Atul Goel definition. You see that after transoral we remove almost all the odontoid, the anterior arc of C1, and all the clivus up to the spheno-clival synchondrosis. And the Chiari malformation disappeared, to confirm that Chiari 1.5 is associated to an anterior crowding of posterior cranial fossa. But few months later on, the odontoid grew up again along with the clivus, as demonstrated by also CAT scan along with the MRI. So we shift to redo surgery. But we have some disappointing experience as well with transoral. Beside the brilliant solution, we have also some delusion. You see this post-traumatic non-union case. After surgery, we are confident that we have done a good job, but due to macroglossia, MRI showed us that before surgery is quite the same of after surgery. So we were very, very confused and disappointed about that. But few months later on, naturally, without doing any reduced surgery, the situation stabilized, and all the tissue and all the musculoskeletal and also ligamentous components further adapted to the surgical field. But retrospectively, considering this case, we can think that in a macroglossia situation, probably the midline splitting of the tongue, as well as the extended transoral maxillary mandibular swing approach can be a solution. But also in this case, we have the risk to damage some cranial nerves like the 9, the glossopharyngeal nerve and the upper glossal nerve. And so to stabilize among transmucosal approach, which is the best, is a job for cadaver lab. And in cadaver lab, we both experienced the transnasal transoral approach with the same cadaver and performed a measure of transnasal domain and transoral domain with the two tools mimicking the endoscope. This is a transnasal and this is a transoral difference of surgical domain in favor of transoral, as well as in AP X-ray examination. You see that in the nose you have this surgical domain, in the mouth you have this surgical domain, about the double. And also with CAT scan we confirmed the superiority of a transoral compared to transnasal, and also further investigated about the possibility to predict the surgical field and the availability of the upper part of the craniovertebral junction, since we know that transoral has the limitation of the clivus. And with the dotted line, we can predict how high we can go with transoral in order to control the upper part of the craniovertebral junction. Again, neuronavigation with the isolated head is able to clarify that again transnasal is less effective in transoral in surgical domain. But the solution of the question is not one is better than the other, but both are useful to tailor the best surgical approach to the single pathology, to the single patient. Thank you so much for your attention.
Thank you.
Thank you, Massimiliano. Good to have you here as always. So I don't think we have time for questions and answers, Nasser. I think we should conclude. What's your opinion?
Yes, we just have one question over the Q&A panel.
Yes,
would you like
yes,
to answer
we
this
mentioned-
question and then we close the webinar?
I think this question was already answered during the talk. When to do a consular resection to manage Chiari. I think this was answered during the lecture.
And so I think it's time to close the webinar. Let me thank all our distinguished speakers, all participants, and I will give the mic back to Professor Oscar Alves to say closing remarks and close the webinar. Oscar.
Nasser, once again, thank you for leading us and organizing this webinar. It has been a pleasure to be for the second time with you organizing a webinar. I noticed that in the peak audience, we had like 270 participants, which is really good in terms of education, neurosurgical education. I would like to thank to all my colleagues here, the panel, excellent lineup of surgeons and friends. And I guess you gave a lot of tips and tricks that are very useful for the participants in their practice. So this was a joint organization from International Academy of Spine, which Mehmet Zileli is also co-chairman. And I invite you to look at our website. We'll have more activities. And we are happy to collaborate with you, Nasser, in the future. Thank you so much.
Thank you, Arch. Professor Zileli, do you like to say anything before we close the webinar?
Thank you. It was a great event, really. Thank you, Nasser. Thank you, Oscar, and all the speakers.
Thank you.
Wish to meet
Thank
again
you,
in
thank
future
you.
meetings.
All the best.
Thank you.
Bye-bye.
Goodbye.
Thank you very much. Goodbye. Thank you. Goodbye.